Welcome everybody to the Public Board of NHS England. A break with habit actually is as individuals speak for the first time. It's a request we've had from people watching the webcast. Just for the first time we speak, if you can just introduce yourselves, but which I don't mean the full bio, actually just who you are and are you a non-executive or are you an executive director, etc. That would be very helpful. Richard Meddings, Chair of NHS England. Apologies for absence for this meeting. Vin Duaka, who was with us this morning, unable to be with us this afternoon. Sarah J. Marsh is away. And also actually Wal Collada and David Behan, again, who are in the private board this morning, are unable to join us this afternoon. And also Mark Bailey, who was dialing in this morning, again, unable to be with us this afternoon. Can I just test whether, for the public board, there are any new declarations of interest that any of the board need to make? Thank you very much. Can I just get approval from board colleagues for the minutes of the 16th of May meeting? Can I adopt those? Thank you. Thank you very much. Well, let me just share some opening remarks from the chair. And since we last met, clearly a lot has happened, very notably a general election and a change of government. We've also had actually a cyber attack, which has been impacting our services, certainly in southeast London. We had a global IT outage, which impacted, I think, starting last Friday, and where the impacts are not just in the NHS, but generally across the commercial sector, continuing to have some impact. And we also continue to see strike actions. So we had further strike action in June. I raise those not because I want to be particularly depressed about the continuing challenges, because I want to thank staff across the NHS for their very hard work actually in keeping vital services going for patients through each of these incidents. Now, I'd also just like to thank two of our colleagues, one actually who has apologised for this meeting, but that's Sir David Behan. And David is leaving the board of NHS England, timed out effectively as a non-executive director. He has been a really superb member of the board, and he was originally the chair of HEE, Health Education England, from 2018. On the NHS England board, he served both as chair of the People and Remuneration Committee and also the Workforce Training and Education Committee, and also as a member of the Quality Committee. And the oversight group, the committee that oversaw the merger of essentially four of the NHS England head office entities, if I call them head office entities, chaired by Wal Collada. David also served very, very diligently on that. And so I'm sure the board will join me in wishing David huge success and as he continues now as chair of King's College NHS Foundation Trust. And just to record in the minutes our huge thanks for all the work that he's done for NHS England. And I'd also like, it's slightly more awkward because I think you're here actually, Helen, so it's always slightly more awkward, slightly embarrassing for you, I think. But Professor Dame Helen Stokes-Lampard is going to be leaving us, and she's leaving us to become the Chief Medical Officer for Health in New Zealand. As I said this morning, actually, the great agreement is that I think you're going to stay with us almost until the very last day before you get on a plane to go to New Zealand, and we welcome that. And while you've been with us on the board for a relatively short time, you've been pivotal in our work and our piloting, for instance, in primary care, and also in our quality agenda. And actually, you've been a force for good more broadly within the NHS for the whole of your career as a practicing GP and a serving academic, and also as a president of, I think, Royal College of GPs and the Academy of Medical Royal Colleges. So thank you very much. And we will miss you, although you're probably going to be with us for at least a few more weeks, I think.
Thank you.
Now, with those two departures of the board reference, I just wish to say we are looking to undertake a non-executive director recruitment process. It got slightly delayed because of the election, wholly understandably, and we're now engaged with our colleagues in the department in finalising on the timeline of essentially a new advert which will kick off that further recruitment. This morning, can I just reflect a little bit on the board meeting, the private board meeting that we had? We changed the format, which was helpful, on committee approvals, and what's quite often missed is actually the scale of work that colleagues on the board do outside this boardroom. And it's also actually outside committees, but just as a matter of interest, that we had, I think, very good feedback and conversation around topics covered since the last board at various of our committees. So the Digital Data and Technology Committee gave a good report, Audit and Risk and Assurance, obviously, the CFO Advisory Group Committee, NOMSCO. We also had Quality Committee feedback, where we're looking very much, Robert, under your chairmanship, taking over from Simon. But we are, as we agreed at the board this morning, looking at how should we reshape and focus that committee's agenda, and I think that's a very sensible step. And then clearly we have, I'll call them the people committees, two of those, the People and Remuneration Committee, and the Workforce Training and Education Committee, both of which David gave very good feedback to the board on in his valedictory remarks. And then the other topics covered this morning that I will mention, there were several that I won't mention, but actually a very good conversation to an approach to frailty. So how do we scale our work in serving patients with frailty? Very good discussion only actually an hour or so ago on innovation and how do we encourage and catalyse and scale innovation, and also actually a review on long-term infrastructure requirements and long-term capital needs. So I think a very rich agenda this morning in the private board. Now, since the last time we met, I've been on several visits across England, so including Nottingham University Hospital, St George's NHS Trust. I went to an extremely, really impressive, and many of them are, but really impressive primary care practice in London Fields in Hackney, which was the Richmond Road Medical Centre, wonderfully embedded in its community, and actually it really was a truly outstanding visit for me. And also I went to see Shropshire, Telford and Shrewsbury. And during my time on these visits, I did have the opportunity to speak to clearly frontline staff and to patients, as well as actually seeing some innovative ways to improve services. Whilst I was in Nottingham, I heard directly from the team regarding the improvements that are occurring within their maternity and neonatal services following their independent review. And at St George's, it was really great to hear directly from a patient who had undergone a major trauma and surgery. And actually what was interesting to see how a virtual reality handset was actually substantially improving the pace of her recovery and her recovering mobility in a way actually that without that virtual reality engagement was probably going to be just much more difficult to achieve. When I went to Shrewsbury and Telford, a couple of things. We had a really interesting and tough conversation, given some of the pressures that are being seen in that system and in the hospital. But I also had the chance to see actually the progress that was being made on the enabling works in the construction, actually, of what I think will be a very good new and improved building and facility for the hospital in Shrewsbury. We're going to go through the agenda. We'll have a couple of normal items to begin with. So we'll have a performance update, Emily, which I know you'll lead for us, and Julian, you'll also talk to us clearly about the financial position that we currently see. But actually, it was interesting to see published earlier this week, actually right at the beginning of this week, the NAO report. And I would actually say it was a very important report on the financial sustainability of the NHS, and it referenced a combination of long-standing as well as recent issues that we face, including the state of our estate, plus inflationary pressures, and also actually the cost of post-pandemic recovery. And all of those are contributing factors actually to the pressures that we see. And there are others, and we've discussed those again this morning. The NHS has delivered, and this is an important reflection in that NAO report actually, and it's a phrase I've often used, that the NHS is delivering and has delivered record levels of activity in many key areas, and that's certainly true in the last year or two. And if you look at A&E attendances, if we look at hospital admissions, if we look at the number of GP appointments, we're clearly providing record levels of care. But, and it's important, but waiting times and crucially experience, I think it's fair to say, is well below what patients expect, and also what our staff want to provide and attempt to provide. And it shouldn't come as any surprise, given the pressure that the system's under, and yet the scale of its activity, that our latest monthly data shows that across the board, staff are under huge pressure. And whilst they are delivering so much for patients, they also know that there needs to be major improvements actually in how we're operating. The waiting list we saw rose by over 30,000, and the overall backlog now at 7.6 million, with 6.3 million people underlying that 7.6 million on the list. So 6.3 million people waiting for 7.6 million treatments or interventions. And despite the hard works and efforts of staff, we know this isn't, again, good enough for our patients who, when they are on the waiting list, are waiting either in pain and or with significant anxiety. And again, I referenced this morning, actually, which again was a recent publication, and it's actually it's the rate of increase in diagnosis of dementia, and we're seeing more people than ever before diagnosed with dementia, and we have one of the highest diagnosis rates in the world. And we know that whilst diagnosis is key, so we can ensure people get the right support, it does add extra demand pressure and pressure on staff to deal with some of these areas where we're seeing surging levels of demand. I would say, I know not just me, but the board welcomes the Lord Aradazi review. He was actually a member of the NHS England board 3 years or so ago, I think. But we welcome that review announced by government 2 weeks ago. And various teams across the NHS will be working with Lord Darzi in terms of providing him with information to enable him to produce his review. And clearly it's a sort of a springboard to the also announced 10-year plan. And that 10-year plan should enable us all, I think, to build an NHS that is that's fit for the future. And then just coming very quickly and back to sort of diary management, and forgive me, some of the meetings I should also mention that I've had, or engagements I've had since the last board, were with the Dean of the Royal College of Psychiatry, a very good strategy session with Genomics England, so genomics strategy. I had a really good engagement with Lord Bird, who's a founder of The Big Issue and actually a passionate advocate for really addressing poverty and how do we alleviate poverty. A very good meeting with Steve's support with the Medical Royal College presidents, and then meetings with Alzheimer's Research UK and with the UK Sepsis Trust, and then a couple of meetings with Nuffield Trust, one on communication challenges across the NHS, and the second actually was to exchange views with them on their recent research into primary care and how do we think about transforming and supporting primary care. And then I've made a series of presentations or speeches, NHS Confederation Conference, as an induction for national chairs and non-executive directors, the quarterly ICB chairs meeting. So every quarter we have a meeting with all the chairs of the ICBs. I attended the Genomics England Research Summit, an NHS England Clinical Fellows Insight Day. I spoke last week, I think, at the King's Fund Digital Health Conference, and earlier on this week I was delighted to be able to go to it's a lobby group called 50/50, and it lobbies and promotes that 50% of the members of the House of Commons should be female. And I think it was a brilliant evening. The focus of the evening actually was on women's health, and I attended that and was delighted to be able to go. So that would be that's all for me, I think, in terms of a chair's summary. I'm happy to take any questions or reactions, but I suspect we'll be able to move on to the better discussion, which will be the Chief Executive's report. Amanda.
No, not at all, Richard. So can I just start by echoing what, Richard, you've just said in relation to David Behan and to Helen Stokes-Lampard, who've been two hugely valuable members of the board and will be greatly missed. And thank you to both you, Helen, and David in his absence for everything that you have brought to us. In a more positive announcement, though, I would also like, if I may, to welcome Duncan Burton to the board in his capacity now officially, as of today, as the Chief Nurse for England, replacing Ruth May, who has retired after 40 incredibly impressive and dedicated years of service to the NHS. So we wish Ruth all the very best for her retirement. She goes with an enormous, load of gratitude and thanks from colleagues, not just in this room, but across the NHS. But Duncan, welcome. We're absolutely delighted to have you now officially as our Chief Nurse. And I know you bring a wealth of experience from across local, regional, national roles, a real track record of delivery, and actually a real record of values-based leadership to the role. And it is equally, on me to welcome and also thank Dr. Michael Gregory and Robert Cornell, who have stepped up as interim regional directors for respectively the North West and the North East and Yorkshire following Richard Barker's retirement, who again is someone who's given huge service, a real public servant to the NHS over many decades. So we thank Richard, we wish him all the best, and we thank Michael and Robert for stepping up. But it is a good time, Duncan, to be joining us because it is as you said, Richard, an exciting time now with a change of government and a busy time. So I would just like to thank colleagues, particularly in NHS England, for all the work that they have done to help prepare for a potential change of government, which has now become an actual change of government. We have had really positive early engagement with the new Secretary of State and ministerial teams, and the focus on greater joint working between us, like, for example, the inclusion in a town hall event that the Secretary of State hosted, not just for Department of Health staff, for other colleagues in other ALBs and for NHS England was, I think, very welcome indeed, and a real signal of wanting to work very closely with us. So hugely welcome. Early announcements have focused, as you've said, Richard, on the review that Lord Aradazi is doing on current challenges faced by the NHS, and that will feed into the development of a new 10-year plan. Importantly, and again we've touched on this, that will be for health, not just for the NHS. That's really important because not only is it a very different lens, but of course it is the sustainability of the NHS is dependent, or so dependent really, on the health of the nation, and that is one of the issues I think that did come through the NAO report this week, and indeed it's one of the things that was very much, I think, a feature of the COVID inquiry Module 1 report. So huge amount of work that will take place over the next weeks and months on both Lord Darcy's review and those first steps in developing the 10-year plan. But I'm very pleased that already the engagement has started with colleagues across the NHS. Visits are already underway, I know, from Lord Darcy, and it's very clear that the team that are coming in to support the Secretary of State, which we're obviously also feeding into, will be seeing this as a really important engagement exercise with colleagues across the NHS, much wider engagement also with stakeholders and with the public themselves on their experiences and what they want from the future. So it's a very exciting opportunity, I think, for us all to be involved in that. I do just want to highlight as part of this, though, the importance of the 3 shifts that the government talked about as part of the run-up to the election. And the thing that I think is particularly encouraging from this board's perspective is these are themes that we have been talking about ourselves for some time. So the importance of that shift, moving care out of hospital into community and primary care, moving from an analogue to a digital way of working, so better utilising technology and data, and of course that focus on a shift from treatment to prevention. All of those things, improving experience for patients, improving value for money, improving how we use the facilities, the assets that we have within the health service, all of them really ambitious, really difficult to deliver, but all of them right, and all of the things that I think we would strongly recognise as the things that we've been working away at over the past few years as well, and delighted to have the opportunity to really turbocharge the focus on those things. Just talking about early policies, there have been some very specific things that, again, were flagged clearly in manifestos, which we're now very much working with colleagues at the Department of Health and Social Care to operationalise, thinking particularly in these first few days about elective activity, so the pledge to step up elective activity as a first step is something we have been planning on now in the run-up to the election, and are now in the sort of final stages of putting the detail around that. In delivering that, and of course anything else that we're talking about today, we do rely on having the staff around to do the work. So we've been really pleased to see talks resuming with junior doctors. We do also have the forthcoming intention by GPs to take collective action as part of their contractual dispute. So just to note that we did write to the NHS earlier this week to ask colleagues to assess readiness for action that might be taken by contract holders. Obviously, it's not going to be the same as the action that's been taken by junior doctors, but we do know, we've talked about it a lot as a board, general practice, primary care is the absolute bedrock of the NHS. So any action taken in primary care won't just have an impact on primary care, it is the knock-on impact to other services, secondary care, elective and urgent emergency care. So there's a lot of work to do to prepare for a potential impact if that goes ahead. 3 other things, Chair, I just wanted to make sure that I had highlighted to the board. So just linked with the point I've just made about where we are with industrial relations issues. Colleagues will be aware that we're expecting the outcome of the pay review body processes for the current financial year and future years shortly. As ever, we will be and are working very closely with colleagues at the Department of Health and Social Care and beyond to support assessment of affordability. Julian's Finance update is going to give us a picture later of just how important that is in a year we knew was going to be very stretching and is proving to be. Second thing I just wanted to say is we are, again, sort of getting slightly ahead of what Emily is going to be talking to us about shortly, getting ready to set out our expectations and support for colleagues across the NHS in relation to planning for winter. So that will build on much of the really detailed work that was done to put together the urgent emergency care recovery plan, high impact interventions, but we've talked a lot about really wanting to make sure that we are putting a focus on patient safety and patient experience at the heart of our approach to winter this year at both trust and system level. And I think any of us who watched, and I'm sure we all did, the Dispatches documentary a few weeks ago, shows what happens when we don't get that right. And we have to, I think, have at the heart of our approach for winter a recognition that whilst we cannot solve, it's your point, Richard, all the challenges that are facing the NHS by this winter, we shouldn't be, under any illusion about that. There are huge challenges and huge pressures in the system. When we do end up in a situation where patients are not in the right place or they're waiting too long, the onus on ensuring that the care that they are getting is as good as it possibly can be and as safe as it possibly can be is absolutely at the heart of how we need to support colleagues in the NHS to meet the needs of patients. And that will be true for this winter, sadly, but it is something that we need to make sure sits, I think, at the heart of what we'll be talking to colleagues across the NHS about over the next few, days, I think, possibly, because we are looking to get something out very soon on that. Final thing is just on how we work. So colleagues know that we've been through an enormous restructure within NHS England over the course of the past year, 18 months. There's still a massive amount of work now going on internally to ensure that we really do reap the benefits of being the new NHS England with all of the advantages of having colleagues from what used to be HEE and what used to be NHS Digital as part of this national organisation. Equally, of course, that's replicated at regional level. We also have the huge opportunity created over the last, nearly 3 years of ICSs, ICBs, 42 systems across the NHS, as well as all of the structures that were there before. We continue to focus on, under Steve Russell's leadership, but with input from a huge number of other colleagues as well, how we best work as NHS England, with colleagues in regions, with colleagues in ICBs, ICSs, with colleagues in trust, so that the collective whole is as effective as it can be. That feels to me to be something that just needs to remain on all of our radars as we go through the next weeks and months, because we will be, I think, just continuing to iterate our operating model so that we put quality and safety at the heart of everything that we do, so that we are able to respond to the immediate operational pressures, be that winter, be that elective recovery, be that continuing to deliver on our financial responsibilities, but that we are also able to get ourselves ready to input in a really constructive and with a level of ambition that I know we all have into the plans for the longer term, and that we're then in the strongest possible place to support colleagues across the NHS to deliver now, but also to be ready to deliver a very exciting and ambitious set of things for our patients and for our staff over the longer term.
Thank you. Any comments or questions for Amanda on the CEO's update? And the only thing I would add before we move on then to the operational performance, Amanda, just to say thank you very much on behalf of the board just for the pace and diligence and rigour of the engagement. It's always been a strong engagement, but actually in the last 2 to 3 weeks with the new government, I know how hard you and the executives have been working in providing briefings to and engaging in meetings with the new government. And thank you for all that effort, which has been extremely good. Very good, strong engagement. Okay, Emily, can I ask you to give us an update on operational performance?
Thank you. So the paper covers the NHS's operational performance across May and June, with published data varying depending on the source. And the performance story this month is, as I mentioned last time, and I think the time before, one of a combination of impressive achievement at the same time as many areas where we clearly need to do better. And I'll pull these out as we go along. A few weeks ago, Amanda, Julian and I met with all 42 systems over the period of a couple of weeks to test their plans for this year. And it was impressive and encouraging to see the work that's gone in to develop stretching and realistic plans across the country for 24-25, and the work that ICSs have done to balance the delivery of all three critical components of delivery, so financial, quality and operational performance. We're now in Q2, although the data I'll report on here refer to Q1. So we're focusing on delivery mode ahead of the challenges that are always placed on the system in winter. That includes pressure, obviously, on financials, quality and performance. And we're particularly focused on the headline areas of UEC and elective, but the pressures are across all aspects of system delivery. Looking ahead to those challenges, we're thinking through our operational planning for winter, and we'll shortly be communicating with the system to set out our approach to winter, drawing on the UEC recovery plan and the system operational plans, and obviously including the links into social care, which is critical for local delivery. We know we're making progress, and there are some really good examples of that in the report, and we'll cover some in the cancer paper later in the meeting. But there is a long way to go to make the strides required to deliver constitutional standards and to consistently provide the quality and quantity of care that we all want to see. And I've spoken to various systems, including all the ICS leads a couple of days ago, about the impact that the dispatches programme has given all of us on the focus on respect and care as it's delivered locally, particularly under pressure. We have had very constructive early engagement, as Amanda's mentioned, with the new government on what we need to do to return to performance standards, and I'll be able to update the board on that in due course. And as Amanda has already mentioned, on top of business as usual challenges, the NHS has continued to face disruptive industrial action. The junior doctors' strike between Thursday 27th of June and Tuesday the 2nd of July saw 61,989 inpatient and outpatient appointments rescheduled, and 23,001 staff were absent from work due to strikes at the peak of the action. So we recognise that on those strike days, as always, there is an extraordinary effort going in from colleagues to ensure safe, effective and timely patient care. And the places where I'm saying we've got a long way to go are not in any way a comment on the effort that's given every day at the front line, but more on what it takes to deliver day after day across whole pathways and across whole systems. If I then pull out some of the highlights of the performance data, or the key points of the performance data which are in the document, starting with UEC, which refers to data for June 2024. In UEC, we saw high pressure in June, including hot weather, which included several yellow heat health warnings and 4 days of strikes, as just discussed. And all of that creates extra pressure for frontline teams, different cases and different intensities of people arriving in ED. We saw 3.3% higher ED attendances in June 24 than in 23, and ambulance services responded to more Category 1 and 2 incidents in June 24 than in June 23, which is 3.2% increase and a 2.6% increase in incidents, respectively. Despite that pressure, there was an improvement in 4-hour performance in June, up 0.6% on the previous month to 74.6%, and above the 73.3% seen in June 2023. On Category 2 response times, unfortunately, there was a decline in performance, up to 34 minutes and 38 seconds in June, almost 2 minutes above the figure for May, which we put down to increased demand and longer ambulance handover delays at trusts. Clearly, we need to see performance improve as we work towards our overall target to achieve an average response time of 30 minutes across 24-25. Colleagues will also be aware that there are ongoing challenges with the number of patients waiting 12 hours or more to be admitted, transferred or discharged. And June, for example, saw 43% more 12-hour delays than June 23. So we're very conscious that these metrics that aren't always reported as a headline are ones that we need to pay attention to in terms of improving clinical quality of care and patient experience. Overall, the work everybody's done to improve UEC, particularly since the publication of the UEC plan in January 23, and bearing in mind all the actions people have taken in response to the Year 2 letter, which was published in April, means that there's a very clear focus on improvements in the system and lessons learned from things which were trialled in Year 1, which we've taken forward into this year and will reiterate in the winter letter. But as I said, there's a long way to go. We need to make sure we make the most of the improvements that every individual organisation has put in place and make sure we can scale those quickly and appropriately. We need to work effectively across organisational boundaries, particularly locally with social care, but also with ambulance services. And we need to ensure everyone across acute trust takes responsibility for their role in A&E performance, i.e. not just the people in A&E. This is a whole system requirement if we're really going to improve. I'll keep going with the other topics, and then obviously we can pick up whichever ones people are interested in. If we look at electives, this remains a key focus because we need to treat people as speedily as possible, and we've been making progress on our goals in elective recovery despite the impact from industrial action. In May, the total waiting list increased for only the second time since October 2023, with an increase of 31,249 patients since April 24, standing at 7.61 million. That equates to an estimated 6.38 million people waiting for treatment. We look at the key metrics, including long waits, which has been the focus of the elective recovery plan. The 78-week waits decreased in May from 5,013 to 4,597, although 65-week waits increased by 11% from 50,397 to 55,955. We've seen an increase in 65-week waits in recent months, which obviously is not what we're heading for, but it's worth noting that that's increased since the turn of the year. In January, we were looking at 92,213 people, meaning we've seen a reduction overall since the turn of the year. What we've also seen in unpublished data is that the cohort of people waiting for who will have waited 65 waits by September has been coming down over this period as well. In terms of the published data, again, the data shows us that 50% of all 65-week waits are located in 18 providers across the country. So it's clear where we need to focus our efforts, and the elective team has those trust in sight and is working closely with them to make sure they have the operational support required so that we can move towards the target to virtually eliminate 65-week waits by September 2024. And noting that the data on 52-week waits means we still have a long way to go. Those waits increased by 4,911, which is 1.62%, to 307,500 at the end of the month. In diagnostics, we continue to deliver a record number of diagnostics checks in tests and checks. In May, there were 2.42 million patients checked, which is up more than a fifth since before the pandemic. Despite the major increase in activity, however, the overall waiting list has continued to grow. The latest published data shows community diagnostic centres have delivered over 9.58 million tests since the first CDC was launched in July 2021. We now have 170 CDCs approved, with 165 operational, 108 of which are now in their permanent sites. In terms of cancer, which we'll come to later, but just to give the operational performance at this point in the meeting, we improved performance against all three standards when comparing May 24 to May 23. The faster diagnostic standard was met for the third time in 4 months, with 76.4% of patients receiving a cancer diagnosis or having cancer ruled out within 28 days of being urgently referred. Performance against the 31-day combined treatment standard was 91.8%. And in May, performance against the cancer 62-day urgent referral to first treatment standard was 65.8%, which is below where we want to see it. The NHS has set the ambition to improve this to 70% to March 2025 as a first step in recovering performance to the 85% standard. And this month, which is an improvement over the same time last year, represents a positive step in terms of doing so. Finally, on mental health, we've seen pressures remain high across the sector with increased demand, as with the other areas I've spoken about. And the recent industrial action has also shone a light on mental health pressures across providers. The urgent and emergency mental health pathway continues to be under significant pressure, with very high bed occupancy of between 95% and 97% since May 2022. Continued focus remains to improve patient flow and work towards eliminating the inappropriate out-of-area placements, which tend to result from very high occupancy locally. On talking therapies, the 24-25 NHS planning guidance committed to increasing the number of adults and older adults completing a course of treatment with NHS talking therapies to 700,000, with at least 67% achieving reliable improvement and 48% achieving reliable recovery. In May 2024, 56,960 adults and older adults completed a course of treatment with reliable improvement of 67.4% and reliable recovery of 47.9%. Access to the individual placement and support services has significantly improved, with over 36,000 people reported to have accessed this service in the 12 months to March 24, compared to only 26,000 in the year to March 23. The dementia diagnosis rate is 65% as of June 2024 against the national ambition of 66.7%, so steady improvement since January 23. Access to specialist community perinatal mental health and maternal mental health services continues to increase, although we are still short of the target. In the 12 months to April 24, 58,898 women accessed these services. And finally, around 1 in 10 people waiting for a second contact from adult community mental health services had been waiting at least 116 weeks as of April 2024, which is clearly an unacceptable quantity of long waits and which have a negative impact on care for people with serious mental illness and those seeking support for self-care and neurodevelopmental conditions. So we are looking with some urgency on the management of longer wait lists and looking at how we create the same or similar standards in mental health as we have currently in Elective. So I hope that that long list of statistics gives the sense that I said at the beginning, where it's incredibly important to recognise that operational delivery is into an incredibly complex system and a very complex set of patients. And so every day there are extraordinary positive improvements being made at the same time as there are still incredibly challenging targets that we have yet to meet, but which we absolutely think we should be meeting. And the progress towards those needs to be carefully tracked and managed.
Thank you. So look, on operations and current performance, any comments or questions? Mark?
Well, it's great to have the numbers. I mean, the report notes the pressure on GP services, which everyone knows about. But it also notes the launch of Pharmacy First, with over 90% of pharmacists signed up, which is very good news. I guess there are sort of two questions there. One is, are the missing 10% in areas where, I suppose it's how they mapped the areas of unmet need, actually. And it would be a pity if the 10% that weren't signed up were mainly in the areas of unmet need, which seems an unlikely outcome. And I guess the sort of related question is, do we know whether the people that take up Pharmacy First are people who would otherwise have used general practice services? In other words, we ought to see a slight reduction in pressure going with people using this new service.
Should we try and gather two or three questions?
I'll make a note, yeah.
Andrew, do you have a...
Thank you. My name is Andrew Morris, Deputy Chair.
Sorry, you are Mark?
Sorry, Mark Allport, Non-Executive Director.
I've just got a couple of points around the winter plan. So recognising that activity is probably going to increase by about 4%. We've got the stretch of trying to achieve 78% of people going through the emergency department within 4 hours. And unlike last year and the previous year, we've made some attempts to increase capacity across the system. And this year, for financial reasons predominantly, we haven't got that flexibility. And whilst Emily and Sarah Jane have done some really fantastic work around improving flow, and at ICB level and trust level, everyone's focused on doing that, I still feel this feels really, really tight for this coming winter. And we do want to improve on an annual basis, but it is really, really tight. And if I go back a couple of years, I can recall the Chancellor or the then Chancellor earmarked about 6 to 7 billion to improve social care. And I'm just thinking, have we seen any benefit from that investment? Or is that investment just focused on preserving the status quo in terms of buying the existing capacity?
So can you take one more and then have a go at some of those? So, Jane, you were...
Yeah, thank you. Jane Ellison, Non-Executive Director. So just 2 points. One, I mean, great reduction in the long waiters, very long waiters. But I just wondered if you could just unpack for us a little bit what you found in terms of the complexity of the remaining people on that list. And then the second point is actually more, it's in the area of screening and vaccination. Obviously very much welcome our commitment, NHS England's commitment to the global elimination of cervical cancer, which is within reach, and obviously the HPV vaccine is critical to that. Been a lot of coverage recently about the Department of Education having a real focus on children who are out of school and I'm imagining there's quite a strong relationship there in terms of children out of school and children were struggling to access in terms of some of the school-based vaccinations. So I just wondered if there's an opportunity there, sort of for some strategic joined-up thinking in that area.
So do you want to take those or even allocate any of those you want to your
I was going to see
colleague?
if Steve wanted to come in on HPV, but I'll give him a couple of minutes. Sorry, I should have introduced Emily Lawson, Chief Operating Officer. So just on pharmacy first. So I had absolutely been asking that question about the sign up, as you would expect, and there is not a correlation with areas of particular need. It's quite spread out. And of course, one of the benefits of Pharmacy First is that pharmacy disobeys the access to care rules and tend to be in areas which are underserved by GPs generally. So there is a higher concentration in areas which are underserved. So one of the good things about Pharmacy First is it's broadly increased access, made it more convenient for people. In terms of the reduced pressure, I have to say I haven't heard this back from the system, and at the moment we wouldn't have data that would necessarily show that. We can see all of the interactions that are going on in Pharmacy First, although I have to say at the moment the data's a little bit lagged for my liking. But I wonder, and there are plenty of people in primary care around the table who might want to comment, but I wonder if it's a bit similar to what we've seen in UEC and linking to Andrew's question, which is the improvements enable us to absorb the increased pressure and increased need for access year on year rather than to actually create additional capacity. I don't think I'm 100% sure that the stats won't give me the ability to say that right now, but that would be, I guess, a question for us to look into. I don't know if any colleagues in primary care want to come in on that. Maybe when
comment at all? Or?
Yeah.
When you asked the question, Mark, I was sort of grinning to myself that we have so much unmet need in general practice that what's happened is that you've taken a bit of that unmet need and dealt with it in a safe and appropriate way. But all that's done is, one would hope, is allow those with slightly more complex issues to get to the front of the queue, to get to access what little is there. But Amanda earlier mentioned industrial action looming and the risk of debate in primary care, and we're already starting to see tension as general practice is pulling back from doing all the discretionary stuff. And I think that's something we need to watch, and it'd be interesting to see how the statistics evolve over that as well. I think it's going to be quite difficult to disentangle those statistics because it's so nuanced and it's difficult to pull out. It's difficult to measure, Mark. So thank you. Thanks, Amanda. Thanks, Emily.
I think the other thing to be aware of is that we are in year 2 of PCOP, but of the primary care improvement plan. But year 1 was a lot about hitting sort of foundational implementation of things that will then deliver a benefit. And this year is about making sure people can actually get benefit, for example, from digital telephony. Digital telephony doesn't actually improve anything until you've got the triage and the people in the surgery at the right time to treat patients appropriately. So that is what we need to focus on and what the primary care team is focused on at the moment. Andrew, in terms of your points about winter, they are obviously well made and well taken, and this is what the team, as you say, which is not just the team in NHS England but teams across the country who've put in place improvements over the last 18 months, but before that as well, obviously, in response to the UEC, the plan that was published in February 23. We have made substantive improvements. Last winter was the first winter for, I can't remember how long, but somebody will remind me, where we actually improved winter performance, although we should also be aware we didn't have a deeply problematic flu spike, right? So I don't want to put too much emphasis on the operational improvements. They clearly enabled the system to be more resilient last winter than previously. And we've got a long way to go. And there were additional beds put in last year that we've asked systems to maintain for this winter, but there isn't additional money for yet more beds this winter. So we absolutely have to, we collectively, the NHS, not just we, NHS England, work to put the productivity improvements, the flow improvements in place, or there won't be the capacity in the right place at the right time to be resilient in the same way this winter, which is why we're writing out now. Not with a whole bunch of new stuff, because we took the time to work with systems to write the plan in the spring and update the plan in the spring. But to just make sure systems have got the support and the lead time to put in place these improvements pre-winter and to identify which are the ones that will make the biggest difference in my system. Because everybody is doing something, but nobody is doing absolutely everything to the sort of maximum point of implementation. So that's what we want to focus on over the next few months.
So Emily, if I interrupt, because we had this conversation again briefly this morning in the board, and I have this sort of rather tedious habit of reciting a number of facts that I sort of learned.
Please do.
And they were what I call operational or managerial interventions by Amanda and you and,
yes.
and the exec team down through the ICBs and into the trusts and so on. And engage with the local authorities, whether it was 5,000 additional core beds. I think you said that we would hope to lock in the same number, but we haven't got funding for another step into a greater core bed capacity. We did 12,700, I think, square bracket the number, but virtual ward beds, which is after, I think, about 18 months of investment, we've grown virtual ward capacity, which allows for step up and step down care, and again was really powerful. And very early, we'll hear about vaccinations later on in this board, but there was a very proactive vaccination programme for flu and for COVID, prosecuted very, as I say, proactively. There was that 40 million additional funding targeted into particular local authorities where the prior year they faced particular challenges, and so they got additional support to allow them to provide better capacity in the community to enable the flow, the discharge flow. And there are a series of these steps. And the message I'm getting back, though, I think, is that this year we're hoping to lock those in, but actually we haven't stepped up again. We're having to use pretty much broadly that same capacity. Is that right?
I think that's right, but I wouldn't underestimate. Look, I'm really balancing between wanting to say, look, I think it will be hugely challenging and I don't want to be overly optimistic with, I still think there is massive amounts of opportunity in the system to do better, right? I think both things can be true at the same time. So virtual wards, for example,
we're going to look at occupancy.
Most systems were not at, 75, 80% occupancy. Everybody has now got that in place. That's improved.
I don't know who that was, but
but it was striking.
No, it was the microphone, or whatever, the loudspeaker or microphone.
So we, a bit like I said about PCART, but to it, the first year, I'm pretty sure it's not me, because I'm really staying very still right now.
I think we all are.
The first year of the primary care improvement plan was about putting foundational aspects in place, and this year is about ensuring everybody has the capacity to really do something with them. The UEC plan a bit less so. People both put in place and delivered against improvements last year. But as I said, no, there is no system that is maximising all of the interventions that have been laid out. And for some of them, it may not be the right intervention. But we laid out in the year 2 letter, and we will be clear in the winter letter we're sending out shortly to say, look, you really do need to have the following things in place because they work. There is not a sort of not invented here thing.
And did that look at community beds? Sorry, I was probably rather disturbed by the sudden squawk that came from. Is that looking at the community beds?
We have an audit now of community beds, which we did for the first time last winter.
Very good.
We have less ability to control community beds because, of course, only half of them are NHS funded, directly NHS funded. But the flow work is focused on acutes, but also obviously affects community as well, as far as we can. So there are lots of opportunities to go further, and it will be really tight at the same time.
Okay.
And then on complexity, to your point, the last published data we have on complexity, because it isn't something that's routinely analysed out of the long wait data, is from August 22. And I think it's likely to be different now because of the focus on reducing long waits at this point. And at the point at which we looked at 104 week waits at that time, about 37% were what we call, which are technically complex, which means the case is not suitable to be moved to another provider, for example, because of the need for combination of care at that site or by that particular clinician. I think given the focus on long waits, I wouldn't expect that to have got much better. And certainly when I look at individual challenge trusts now, because we look at the ones which are finding it hardest to reduce 65 weights, for example, there are particular specialties, for example, complex gynecological care, which do come up routinely in individual trusts where it is the combination of different clinicians all needing to be present at the same time, which can be very hard to schedule for patients, but I can't give you a statistic on it. Should we ask Steve about
You're going to pass that question
HPV?
on.
Scared to speak now in case it comes. Anyway, so hello, my name's Steve, Chief Delivery Officer and National Director for Vaccine Screening. So Jane, just to your point, first thing just to say is Amanda announced our ambition around 9 months ago to eliminate cervical cancer, which is absolutely, as you say, within reach. Colleagues will know this, but it's worth repeating that 99.8% of cases are preventable. There's about just over 3,000 new cases each year across the UK. So it is worth going after. And as you say, we are not that far away. We need to get to 90% vaccination rate for HPV. We need to get to 70% of screening and 90% treatment. We are at 90% treatment, and the other two are within touching distance. But of course, that means they're the hard yards as well. So over the last year, we've done quite a number of tactical things to try and improve vaccination rates, in particular with a number of catch-up campaigns. And to try and answer your specific question, we were assisted in that in some respects by a change in the vaccine. It previously required 2 doses, it now only requires 1. That is good because it is more likely that people will become fully protected if it's a 1 dose rather than 2. And the primary delivery is through school-age immunisation services. That gave us some capacity. So we used that capacity, we left the funding in, quite rightly, and we used that capacity to run catch-up for people who hadn't been vaccinated, and also to pilot some out-of-school offers. Now, they were attached to school services, so I think your point of could we go further for people who are not in school is absolutely right, and something that we will go away and have a think about. We're hoping, come the autumn, which will be the year anniversary, to share some really interesting opportunities, both in screening and vaccination, that might get us closer to that ambition to eliminate cervical cancer.
Thank you very much.
Thank you. Amanda, do you want to come in?
Yeah, so if I could just jump us back a second to the conversation we were just having about winter. 2 things, Emily, as I listened to your extremely clear report. One is, it strikes me as you're talking about it, this is not going to feel any easier for staff over the course of this winter, because what we're describing is a whole load of things that are going to be more mature and hopefully better embedded in ways of working, but actually against a backdrop of continuing rising patient need and demand as a consequence. So my question is whether or not we have given any thought to what we could be doing to support staff, particularly over what is going to, I think, feel like a very, very busy winter period, whether there's any more that we could do on that. Secondly, I think, again, I know you've thought about this a lot already, but given that what we're trying to do is set really clear sort of evidence-based interventions that we're now asking, as you say, the right mix of those to be applied locally, which is right, and that's where the benefit of the assessment over the last 2 years plays in. But we're also doing that against a backdrop of saying, like, this is tough and hard yards asks. Again, second question, just your thoughts on how we then best make sure that we are engaging with colleagues. I don't just mean within NHS England, I mean within ICBs, within trust, within the whole system, because it's an all-in ask, isn't it? Voluntary sector colleagues as well, about how we then best make sure that we understand where some of the biggest risks are, where the biggest opportunities are, and how we might work most effectively with colleagues in this next sort of few weeks, months, to translate all of this good guidance and good evidence and good planning into kind of our best and most resilient plans for this winter.
Thank you. I think that was 3 things.
Sorry.
That's all right. Just checking. So you talked about the increase in demand. The thing that I haven't spoken about is obviously what we're trying to do is to make sure people only end up in A&E when they really need to end up in A&E. And there is ongoingly good work in some systems, but again, not consistently across the piece. So one of the major interventions on flow this winter is to make sure everybody is using clear criteria to admit, pathway standards, and that everybody who is admitted has a care plan, which includes the point at which we'd expect them to exit. Which again, none of these are rocket science, but they are inconsistently applied. And we have evidence from systems that are using them that they make a big difference. Because as we heard in the private board again on frailty, we have people being transported to hospital where it is definitely not the right thing for them, and that makes no sense. So we are trying to mitigate, Amanda, as you say, the risk once you get to A&E by avoiding you being in A&E if you don't need to be. In terms of how we engage with systems to make sure we understand, or we collectively understand the risks and we can do our best on implementation, we're doing a few things. Not all of which are public at the moment, so I'm just wondering if I should talk about them. But one of the things is to build on the work that NHS Impact is doing, to pick up the 2 or 3 critical interventions in flow in UEC that we know make the biggest difference when they're done well, and to effectively write the playbook for everyone so that if you're not currently doing it, you have something to react to. Now, I'm sure people who were involved in Model Hospital or the Modernisation Agency previously, which obviously I wasn't, will have experience of this, but the key thing here is to say, look, here is what we think good looks like, what that precisely looks like, given the flow and nature of your patients, and the physical layout of your A&E may look slightly different. But these are the critical components that we think you need to have in place, and then back that with training and support for staff so that they feel able to both implement the core of that, but also to adjust it accordingly for their systems. And we want system leaders to lead that as opposed to that coming directly from NHS England. In terms of other support, we're obviously continuing with tiering, which, if I look at the data, has been really effective. The systems that are tiered, not just in UEC, but also for elective and cancer, improve more than the sort of next door systems in terms of performance. But we've adjusted the tiering approach in UEC for this winter based on what we learnt last winter about what was helpful and what wasn't, which includes being more directly involved sometimes with trust, and particularly with ambulance services, rather than staying at the level of the system. So we're trying to adjust and be agile in that way, and doing different things for different systems. I do think, this is a personal perspective rather than the plan perspective, is the more we can create the sort of capacity, sense of ownership and confidence in the toolkit for frontline staff to take ownership of improving things where they are within clear guardrails of clinical safety, etc., the more we will see the benefit. And I feel like things like virtual wards, we already see that. There are places where you can see when you go into the control centre that they've really got it, and there is somebody really championing it, making sure it's safe, making sure it's maximally used for patients, and places where they've theoretically done it but it's not quite owned, particularly perhaps not clinically owned, where everybody's doing it but we're not seeing the same benefit. So I think there is a lot of work to do, back to your point about how do we help staff in a sort of handle what will be a difficult winter. Agency is the single biggest thing you can give people to help them feel engaged and respected at work. Not everybody is going to have absolute agency in every situation. That's not the world we work in, but I think we can do a bit more to give people the tools and the training and the framework within which they can then improve things locally for patients, which is what in the end everybody does want to do.
Very good, thank you. Duncan?
Duncan Burton, Chief Nursing Officer. So I just wanted I guess I just wanted to add to that, actually. One of the, I think, the most important things as well is in support of staff is around when we do have those circumstances of patients being looked after in corridors, etc., for, minimising the amount of time that happens, but really what more can we do to support around things like privacy and dignity, making sure patients have got access to food and drink and, all those really important critical factors that, impact their experience, but also their safety as well. So I think, I will certainly be working with you, Emily, and the team in terms of what more we can do to support in that space and support our colleagues in that.
Thank you.
Thank you.
Can I, slightly conscious of time at this point, can I move us on to financial performance update, Julian?
Sure. Building really on what Emily has said, this is clearly a tough year and probably tougher than most. We are dealing with rising demand, rising activity, seeking to improve performance in exactly the way Emily has said. But the kind of total amount of funding that we have put in is broadly flat in real terms based on the measure the sort of government used for public sector inflation. And underlying that, you have costs which are increasing, significantly faster than that measure of inflation. The national living wage is up 10% this year. That impacts on our continuing healthcare costs. We are continuing to prescribe, and by the way, this is a good thing for patients, higher volumes of hormone replacement therapy, higher volumes of direct oral anticoagulants, which mean sort of a far lower risk of heart attacks and such like. So those are good things, but those things create real pressures on spend, and as a result, if you're a provider, sort of baseline allocations are probably less than flat in real terms. That is after we have injected about £2 billion into system allocations. We've agreed plans with all systems, but relative to those baseline allocations, we've had to inject another £2 billion into, in particular, 31 systems to get reasonable plans. So it's tough. The level of efficiency that ICBs and trusts are seeking to deliver this year is, close on £9 billion, about 5 to 6%. That is both sort of cost out and higher activity. So it is really, it is tough. It is really tight. And, providers in particular are really focused on how they continue to improve sort of baseline productivity. But, this is against the backdrop, as Richard, you said at the start, that the NEO have set out of sort of unprecedented pressures due to a combination of poor investment, historic investment in the estate, inflationary pressures, and still recognising there is a cost to post-pandemic recovery. We still have, a couple of thousands of patients at any given time in hospital with COVID. In fact, I think Steve's just sort of slightly understated that number. But, and that's just an ongoing factor in what the NHS has to deal with. And look, our job remains, as Emily has said, how do we provide the best possible care within the resources provided. So, that's where we are. The end of month 2, total system spend is about £300 million off plan. At the level of the NHS, it's about £200 million off plan. So that clearly flags like a real risk as we sit here today. And our clear focus with ICBs and with providers is how we get back onto plan, and how boards in particular, this is not just the Chief Finance Officer's job, this is a board's job, and the executives team job is how they deliver the financial and operational plans to which they have committed. And clearly in some places that is not on track, and we need them to get back on track. Given the position, we've assessed the risk across our 42 systems and their providers. We've identified the 10 systems where we are most concerned about the level of risk they're running. We are doing a short, sharp intervention where they are bringing in, we're asking them to bring in some additional support so we can properly check that the plans that they have said they have are, they've got the detail worked out, they're on track with delivering them, and supporting people to identify if they need to take action to recover those or do other things. We identify that quickly so that we can make sure we get back on track. I will say, though, that you can see that people are making progress. 70% of provider cost goes on the workforce. In aggregate, that total workforce cost in real terms needs to come down by about 1.5% across the country. That is largely being done through reductions in temporary staffing costs. So after 4 years of quite rapid growth in substantive workforce, there's a real focus now on then reducing the temporary staffing costs. We think, by the way, that actually genuinely has a benefit for productivity. It's better for staff that there is less temporary staffing. Last year, that cost went down from £3.5 to £3 billion, and in the first 3 months of this year, The run rate would say we're on track to reduce that to well below £2.5 billion agency this year. And we are seeing now the bank costs coming down as well. So, look, people are serious, they're taking action, but we are going to work with those who we think there's the greatest risk of them not hitting plans to make sure that we are on track. Now, clearly, one of the things that threw us off last year was industrial action. We have had a strike, a 5-day strike, at the end of June, beginning of July. That will impact costs, and we will have to discuss with the government and with the rest of the NHS how we deal with those. And clearly, other further strikes will not only hit operational performance, it will hit the cost base. Look, we are hopeful that between the government and the unions, we can see a resolution to any future risk of industrial action, but that is just one we will need to keep an eye on. So things are really tight. We are not entirely on track as we sit here today. Our focus is working with those systems and providers where we think we have the biggest risk to turn it round, but you can see people are really focused on it.
Thank you. Helen, I know you've got a comment or question, and Robert. So Helen.
Sorry, forgive me, I didn't introduce myself last time. So Helen Stokes-Lampard, Non-Executive Director, and pertinent to this next point, I happen to be an NHS GP as well, partner. Julian, super clear as ever and really helpful, not positive, not exciting and positive, but very important and clear. You picked up right at the end about industrial action. Just to be clear in my mind, and perhaps for others, that what we're looking at here does not include any implications of any additional pay award, any settlement to any industrial action. Those things are not included in what we're discussing now.
No, those things are not. Those things are not included. I mean, we basically have funding to provide a 2% increase in pay. Clearly, we are waiting to see both what the recommendations are of the pay review bodies, the government's response to those recommendations, and whatever other discussions will go on with the unions, but that's not included in here.
So thank you, because you did reference the very significant and very important and welcome increase in the national living wage, which of course for those affected is best part of 10% compared to a baseline increase of 2%. It's a difficult circle to square, so thanks very much, Julian.
Robert?
Robert Leckler, Non-Executive Director. Thank you for that, Julian. It is very tight, and you do an amazing job walking this tightrope. A win towards the end of the last government was the commitment to invest over £3 billion in technology, which I think most of us would say it's not a luxury, it's key to delivering the productivity that you're so focused on. How confident are you that that won't get raided in trying to balance the books?
I don't want to prejudge any decisions this government will need to make as it looks at the sort of total financial picture. I think it's clear from the conversations we have had with the new Secretary of State and the conversations we at least have with Treasury officials that they both want us to materially improve sort of rate of productivity improvement in the NHS. Indeed, they all understand it's pretty important when you think about total economic productivity, given the size of the NHS. And certainly as we talk with Treasury officials, I think they absolutely recognise that if we're going to do that, you have got to invest, and basically technology-enabled change and innovation is going to be at the heart of what we have to do to make the NHS both economically, financially sustainable and continue, to deliver and improve great care for patients. So we will continue to work with them.
Mary?
Director. One of the issues around further investment in pay would be that we would probably retain more staff and also improve continuity of care. which in turn would get people back to work. And so therefore, I just wanted to kind of emphasise that what you're talking about is an issue that if the investment were properly focused, we could really make a change to the health of the nation.
Look, we will be, again, we are really focused on how we work with the Secretary of State on their plans for the 3 shifts that the government that he has set out in their health mission. And, clearly we think the evidence says, and indeed people have been talking about it for quite a long time, that if we can get the right investment into primary care broadly defined and into our community services, we can do a lot to care for people closer to their homes, which is better for them, in the end better for the taxpayer, and means our acute trusts can focus on the stuff that is genuinely an emergency that can only be dealt with in an acute setting. I think that is absolutely the goal and ambition we all share. And indeed, we're pretty focused on working with the Secretary of State and his team and the department to sort of make a reality of that.
Yes. I suppose what I was trying to do, and perhaps I didn't present it in the best way, was to congratulate you on trying to pull that triangulation together to get there.
I'll thank you, Mary, on Julian's behalf. Okay, any other comments or questions for Julian? Clearly, we've gone into this year knowing it's a really tight year. And Julian, thank you for the explanation about how it's trending, certainly after the first 2 months and looking into expectation for the 3rd month. Can we move to the next item, which is, Steve, I think you're up. It's autumn-winter 2024 seasonal vaccination.
Yeah, thank you, Chair. So I'm just going to talk briefly about 3 things. So a brief introduction to the vaccine strategy, a focus on autumn-winter campaign, and a word briefly on outbreaks for completeness. So just picking up the points that colleagues have already said. So everyone knows this, but again, worth repeating, vaccines are the most effective public health intervention, second only to clean water. So they are both good at improving the health of the nation and fit nicely into one of the health missions. And that's why in December 2023, we published the NHS vaccination strategy, which is designed to try and improve uptake of vaccines across a range of vaccine-preventable diseases over time, recognising that there has been a historic decline in vaccination rates. The strategy basically sets out to do 3 key things. So one is a single front door with people understanding what they are eligible for and being able to access a range of different providers in a convenient way that suits their lifestyle, using things like the NHS app and the National Booking Service to really drive up convenience. The second is recognising that one of the key things in the strategy is not just to improve uptake overall, but is to try and encourage and support people who have historically not come forward for a vaccination. These are not people who are hard to reach. It's just that the NHS has not organised the services in a way that they have confidence in and that is convenient for them. So the second thing the strategy makes a big bet on is supplementing that convenient offer, that core offer across general practice and community pharmacy with what we've described as outreach. So vaccines being given in places that people go to, in places they trust, and given by people who have an understanding and experience of their life circumstances to build confidence. And the third thing the strategy says is, we've talked about a number of vaccine programmes already in this meeting. We sometimes have historically looked at them as vertical things. So we talk about HPV, we talk about MMR, we'll talk about flu or COVID. Actually, the third thing is saying 2 things. One, this is everybody's business. So every point at which people touch the NHS, wherever that is, we want clinical colleagues to understand someone's vaccination status and to encourage them to have one and be able to give it to them if they haven't already had it. But also to recognise that vaccines are one part of prevention, and we shouldn't be talking about individual programs. We should be thinking about a person and what they're eligible for in totality, and prevention across the whole, whether it's blood pressure checks, the health check, vaccines, screening, etc. And setting that in the context of what's important to people, which might not be about offering vaccines first and foremost. It might be about a broader health promotion piece. So that's what the strategy says. The reason I'm highlighting that is because what we're trying to do in autumn winter this year reflects some of those things in the strategy. So uptake, which is what this is all about, is driven by three things: convenience of the offer, confidence of people in the vaccine. So do I think it's safe? Do I have the information that I want about it? And complacency. So do I think that the thing that it is going to protect me against is serious for me? And I want to just concentrate on three vaccines that we will have a big focus on this autumn winter, two of which will be very well known to colleagues around this table, one of which is a very important new programme. So the first one is just to remind colleagues on flu. So the flu programme will start in September for children and pregnant women. And it will then move in October to all of the other cohorts, so over 65s and people who are clinically at risk. That is important just to remind colleagues that as it's a change from last year, it's a later start because JCVI has recommended that will give better clinical protection and clinical benefit to people at the height of the flu season. We are awaiting JCVI's advice and the government's consideration of that advice in respect of the COVID programme. But what we have put in place and we have worked with providers on is saying once that advice is considered, we'll make it available obviously, but plan on the basis of something that is broadly similar to last year. And again, that would include alignment with the flu programme. We're at the moment, as you'll see from the paper, putting in place the network, and we're partway through the procurement process for that, and early indications are that there is even stronger interest from providers, whether that's general practice or community pharmacy, than there has been in the past. So that should really help us increase the convenience even more. This year, we talked about last year about co-administration a lot, so the ability to get flu and COVID together if you wanted to do so. This year, you will be able to book that through the National Booking Service. You can book either jab individually or you'll be able to book one together. And you'll also be able to book for yourself and a family member or a friend to go at the same time if you want to do so. And that reflects some feedback from people about something that they felt would be helpful. If I just concentrate then for a second on RSV, which is respiratory virus, so respiratory syncytial virus. I can't even say that. Helen will tell me that I've pronounced that all terribly wrong. Respiratory virus. So this is a virus and a disease that is not new, but it can have quite a significant impact on children and older adults. So RSV has driven about 30,000 hospitalisations each year in under fives. And it drives about 9,000 hospitalisations for over 75-year-olds. Around 20 to 30 children die each year from contracting the virus. And Helen will know better than many that in addition to that more serious end of the spectrum, it also drives lots of contacts in primary care and general practice in particular. So the great news is that in late 2023, a vaccine which has gone through a number of clinical trials was authorised for use by the MRHA, which is the body that tests the safety of vaccines. And the vaccine that's been authorised and chosen for use has the potential to reduce those hospitalisations and deaths by up to 80%. So that again is really quite significant, both in terms of protection, but also the wider NHS picture. So this is a really important kind of, Amanda used the phrase, all-in piece for the NHS. We are mobilising we will start to deliver the campaign at quite a big pace. We've had quite a short amount of time to plan it. But it will start in September, and there are two parts to it. The first part is a service to protect infants, so newborns and infants. That is going to be delivered by offering pregnant women a vaccine at around 28 weeks. And so those women who are pregnant on the 1st of September and are 28 weeks plus will be offered the vaccine. That will be delivered largely through maternity providers. And then, of course, as more people become eligible at their 28th week through the season, they will be offered a vaccination. The second part is for people who are over 75. And this will be what's called an all-year programme. So as people turn 75, they will be invited by their general practitioner to come and have a vaccine. Now, we want to vaccinate as many people as possible in advance of the winter season. And so we're going to run a catch-up campaign, in effect, for those who are already over 75. And we're going to try and vaccinate as many of those people as we can who want to be vaccinated in September and October, because that will maximise protection. So those are the sort of three big seasonal programmes for autumn and winter. And then I won't cover it in huge detail, but to make colleagues aware, it's in the paper, there have been a couple of areas of outbreaks, so in measles and in whooping cough, both of which are preventable through vaccination. And we've just put a little bit of information in the paper to highlight the work that colleagues have done up and down the country to try and improve the rates of MMR vaccination and to reduce the outbreaks. And those efforts have been successful in vaccinating a large number of people after 2 million people were invited by the NHS to come forward. This is one of those painting the fourth road bridge things. You just have to keep going and keep going, because MMR vaccination rates are still lower than we would like, and particularly so in London, where there is continues to be a measles control group in place. And on whooping cough, the vaccination for that is pertussis. That is also given and offered to pregnant mums, and that offer is a little bit more fragmented than we would like. So we're working with maternity service providers, with Duncan and his team across the country to try and put a slightly more consistent offer to women in place. And I'll end by just sort of highlighting the point we made earlier about thinking about people rather than programmes. So those of you who have been paying close attention will spot that for pregnant women, there are 4 vaccines: flu, COVID, pertussis and RSV. And actually, the conversation Duncan and I and the team have been having is we've got to pivot how we think about these, rather than thinking about RSV, flu, COVID. We think about the maternity offer that exists in secondary care, but also importantly, supplementing that offer in other convenient ways that people might wish to access a vaccination. And of course, there are people who become pregnant and don't have contact with the NHS. So something that, again, we need to really carefully lean into. And I said I was going to finish on that point. I'm going to make one more, an apology, which is just, we've talked about the NHS a lot. However, one of the things that is really important, and again is part of the strategy, is the NHS is an important part of this, but it is not the only part. And the contribution that the voluntary and community sector make and local government make is completely critical, particularly in the context of our ambition to serve people who we have underserved in the past. So that's, hope that's helpful. Obviously, you haven't taken
very good. I mean, very good and extremely clear walkthrough of this autumn-winter seasonal vaccination programme, particularly with the new elements to it. Can I open for questions? So Mike and then Helen. I did see Mike.
Let's start right.
Mike Cooper, non-exec director. It's great that you're working on accessibility and convenience, and particularly for underserved groups. So that sounds like a massive step on from the past. You talked about one of the critical criteria being confidence, and that's, I suspect, down to how we communicate with potential vaccinees. Perhaps it would be helpful just to unpack that a little bit and talk to us about what you will be doing around communication and building confidence.
Should we gather? So, Helen?
Builds perfectly on what Mike said. Thanks, Mike. Asking for a friend. Co-administration. We talked last year. There was a big push on co-administering flu and COVID vaccines. It worked extremely well, but there wasn't a huge push publicly for that. So confidence in public from having co-administration of vaccines. I'm thinking of those pregnant women being offered 4 vaccines and the over 75s will be offered 3 this winter. I think the comms on this is massively important because, to be candid, the efficiency to the NHS is massive. Giving 3 or 4 vaccines simultaneously costs a fraction of giving 3 or 4 separately. And it is, in my experience, generally, and I'd like to hear it from you, completely safe to do so. The immune system is very, very good at it, but how we build confidence in people, which will allow us to vaccinate far more people swiftly and effectively, would be wonderful. And P.S., this is fantastic work. Thank you so, so much. It made me very happy.
Keep holding these.
Yep.
I know Mark wanted to come in.
Yes, I mean, it's an enormously important programme, and it's very good news that there's a respiratory syncytial virus vaccine, which is very scary for a parent of a young child, really scary, and it does put them in hospital. Yeah. And equally, it's a nasty infection in old people as well. And this programme has to be critical to managing the winter pressures. My question is, looking at the data on MMR, the question is how effective the emails, letters and texts to the million parents were, because when I look at the vaccine delivery, you sent 1 million letters to quite a wide population, but there were in fact only a total of 361,000 MMR vaccines delivered, which suggests that it may not be a very successful programme, that's not necessarily the fault of the programme. It's just that actually it may be that people are quite resistant, sadly, to getting vaccination against, again, another nasty set of infections, which have, where the vaccine has transformed a lot of lives of people who would otherwise, congenital rubella, for example, virtually gone, measles, a killer, mumps, or orchitis.
So there are going to be 2 more coming at you. Is that all right to batch in? That will be a batch of 5, Steve. So Tanuj and then Robert.
Very quick add-on. I thought it was a great paper. Tanuj, Associate Ned. Great paper. I actually was going to speak about lessons learned from communications in the past, and that's been covered. I want to shift the same kind of thread to education in the community, right? I mean, even with all of the stuff that's done, we often meet people with serious concerns about vaccination, and comms is one end of it, but it's sort of education with the community, and how are you thinking about it, partnerships in that space, et cetera, et cetera. Yeah. Thank you.
And then lastly, Robert.
Yeah, so I think it's a terrific programme, and obviously we've learnt a huge amount through the COVID experience and vaccine hesitancy and all that. 2 questions. One is so others have asked about sort of confidence and nervousness. I'm more interested in the complacency, which I think there probably is a lot of, and particularly around COVID. So what's the messaging to address complacency? I mean, you don't want to scare people. On the other hand, you want to make people aware of the risk. Is that media, or how are you doing that? The second question is just what's your ambition in terms of vaccination rates in the over 65s, for example? I mean, do you have a target in mind?
So there, you've got 5 comments or questions, and you can probably answer some of them as sort of
I'll wrap them
thematically.
up.
But I'll throw one specific, which Steve might know, either of the Steves. Do we know what currently the flu is going through Asia, Australia, Asia? So have we got any information about what might be coming our way? We know that?
I don't actually.
I haven't looked at that recently. Helen, you are going to New Zealand?
It was all about the COVID in New Zealand. No, I haven't heard this yet.
Jason. Monday said it was too early to
Yeah.
Too early, okay, fine. All right, sorry. Thank you. So Steve,
I'm glad it wasn't just me that couldn't answer that question. So those questions fit exactly into sort of confidence and complacency. And Helen, I'll deal with your co-admin question as well. So these are the 2 risks that we see in terms of uptake. The one that is most material is complacency from the kind of engagement that we've done. And that is partly because the perception about the severity of the disease has gone down in people's minds. Not everybody's minds, but in general terms, particularly in younger people, the perception that some of these diseases are serious has gone down, and therefore the appetite to take up the offer has dropped. And there's also, honestly, a bit of vaccine fatigue, which is why we have to think about it slightly more broadly. On the point around education, we've learned this in COVID, we've learned it in MMR, we've learned it in polio. And you have to do lots of different things. You're absolutely right. Sort of media-based comms is one thing, it will serve a certain demographic, but actually some of the most effective things, some of which are still in place but not totally, are things like community ambassadors. So people want information. I think that, again, the research that we've done shows that. Most people are interested and prepared to get a vaccine, but they want to understand it. And they want to understand it from somebody that they trust. And that is not always, I'm about to say something very career limiting, that is not always an NHS clinician. So use of community ambassadors and that sort of the voluntary and community sector has been phenomenally important. And again, we've learned that in MMR in London. So big comms campaign, but also what we're just about to do is a very targeted campaign in North London based in the community. That also sort of speaks to Mark's very reasonable challenge on, well, that was a lot of invites, did it work? And I think the answer is, we'll never know cause and effect. Just to reassure people in terms of our green footprint, it's not letters, there's a combination of text, app, and so on. And I think with MMR, our view was, given the measles outbreak, you have to do everything, and then you have to do it again. Yeah. Because even if 1 million invites gets us 370,000 vaccinations, that's 370,000 more than we had before. But we should continue to try and hone how we do it.
Yes, but those 370,000 were for all.
They were for all. That's right. That's right.
This was only
So, and we don't know within that group who would have come forward anyway, because it's not, you don't drive people to a national booking service. It has had some evaluation with UK HSA, which is in draft, and we're going to look at that with the team again when that's finished. And then, so I think that sort of picks up Mike's confidence point. So I'll give you a different example. Polio, when we were trying to encourage polio uptake again, we did lots of inviting. We then went for a model where school nursing services, school-age immunisation services phoned people who were not vaccinated to have a conversation about what information might you want and so on. And there was a very large number of phone calls made in the nearly 10,000, and around 1,000 people after that then went and had a vaccination. So again, it's hard yards on this. And we'll continue. I think you just have to continue to learn because it's different in every community. And then finally, Richard, apologies for timing. On co-admin, so again, what the research says is that lots of people would like to have co-administration. Our offer last year was a little bit fragmented. We've made it easier this year. You're right, it's much more efficient. We've organised it to largely have a couple at one time, and there are some that you can't co-administer with each other. So not everything can be co-administered with COVID, but RSV and pertussis or whooping cough can be. So we're trying to work out the best way to approach that, and also to give people choice so that they don't feel like they have to have too many at once if they don't want to.
Steve, thank you. I mean, very good answers to those questions. I'm going to move us on, I think. Outside, I mean, wholly separate. I wouldn't mind knowing something just separately. How powerful is the NHS app, given it's got 34 million subscribers, as a source of information and nudging or prompting to vaccination? I'd quite like to know how that's going. And how
we can share the numbers with you. The app was very effective last year, so yeah, we can share that with you.
Very good. Thank you very much. Okay, if the board's happy, should we move on to item 6, which is an update on cancer diagnosis and treatment? And I think, Peter, you and David are going to, I think, lead on this. Is that right?
Thank you very much. Yes, Peter Johnson, Clinical Director for Cancer in NHSE. You've had a paper setting out the headline messages. I will recap briefly. Essentially, we have a lot of cancer. We have approximately 1 in 2 lifetime risk in my birth cohort of developing cancer. As the other alternative causes of mortality have fallen back, so cancer has become the leading cause of death under the age of 75, greater than cardiovascular, stroke, liver and respiratory disease combined. Despite the increasing incidence, we see a continued linear drop in mortality from cancer and an improvement in survival figures in this country, but we started at a lower baseline level than comparator countries. And this is largely driven, not entirely, but largely driven by the fact that most cancers present at a later stage, generally speaking, in the UK than they do in other countries. We've therefore focused our efforts in terms of trying to improve survival on improving our rates of early cancer diagnosis, which clearly has a variety of incremental requirements, all the way from public awareness through to presentation to GPs, through to referral, through to diagnostic services. And in focusing on earlier cancer diagnosis, we have encouraged the referral of people in greater and greater numbers for investigation of symptoms. The diagnosis of cancer is dominated by people with symptoms. More than 90% of cancers are diagnosed in people who present with symptoms of some sort or another, and a great problem for colleagues in primary care, of course, is that in many cases the symptoms are not at all specific to cancer and could be due to a variety of other causes. But 90% of cancers present symptomatically. I'll come back to the ones that we pick up asymptomatically through screening a bit later on. In order to drive up rates of early diagnosis, we've encouraged more referrals. We've seen a 10% annual increase in referrals over the last decade or more. Back in 2010, we were seeing around 1 million referrals for possible cancer into the system. In the last year, we saw 3 million. And so the compound effect of all this is to produce enormous pressure, particularly on diagnostic services. Important to recognise that of the people referred with possible cancer, more than 90% don't have it. So our so-called conversion rate, the number of people referred and the number of people who actually have cancer, it's about a 6 to 7%. So we see an awful lot of people in order to make sure they don't have cancer. But the pressures this has imposed on diagnostic services have been very significant, and this is what's led in large part to the performance challenges that we've seen over the last few years, whereby we have seen our speed of diagnosis gradually dwindling. This has been reversed to some degree in the last 2 years by the investment that we were hearing about earlier, particularly in community diagnostic centres. The majority of cancer diagnostics come down to some form of imaging, whether it's ultrasound, CT scanning or MRI, or endoscopy in large part, followed then by a biopsy and cellular pathology services. And that investment, I'm glad to say, has started to turn the situation around. As Emily said earlier, we met the faster diagnosis standard to rule in or rule out cancer within 28 days in over 75% of people earlier this year, and continue to do so. We have stabilised the situation whereby we measure from time of diagnosis to initiation of treatment with a target of 62 days. We are not where we want to be on that. The target is 85%. We're in the mid-60s at the moment, so we clearly have an enormous amount to do in order to recoup that deficit that has built up. We have, however, brought down the number of people waiting a long time past 62 days, which had built up during COVID, back to the levels, in fact, lower than the levels that we were seeing prior to the pandemic. So other than simply seeing more and more people referred on urgent suspected cancer pathways, what we need to do is to be smarter at seeing how we can pick up cancer at an earlier stage. So we have a number of case-finding initiatives to try and target the groups at greatest risk of cancer, the most productive of which at the moment is our targeted lung health checks, whereby we are checking people's smoking history from their primary care records, making a risk assessment over the telephone as to their likelihood of developing cancer in the next 2 years, and for those that are more of a 1% than a 1 or 2% risk, inviting them for a low-dose CT scan, in the main part provided in a community setting located near to where they live and work, in many cases on mobile CT scanners. This has been very successful. We've diagnosed several thousand cancers in the last couple of years since we started running this programme, and most strikingly, these are being diagnosed at an earlier stage in much higher proportion. Historically, 25 or 30% at most of lung cancers would be diagnosed at an early stage. In the lung health checks programme, that's over 75%. And also, very significantly, because we've been targeting the communities with the highest level of deprivation and the highest rates of late diagnosis of lung cancer, because we saw that there was an inequality gradient from the most well-off to the least well-off, with the least well-off most likely to be diagnosed with late-stage lung cancer, we've actually, through targeting that, we've managed to invert that relationship so that the people living in the worst-off communities are now more likely to have their lung cancer diagnosed at an early stage, as a direct consequence of this programme. And I think that's a very important message, that taking healthcare to people in the communities where you most want to target them is something where we can move the dial. Very important finding, and one which I think we will be replicating in a number of other areas. At the same time, we want to make sure that we're managing and helping the people referred in as efficiently and effectively as possible, so bringing innovations into the area of triage of our referrals. The notable case is lower GI cancer, colorectal cancer, where the implementation of fecal immunochemical testing for people presenting with symptoms, we already use it in the screening programme, but using it for people with symptoms to triage out the people at highest risk of actually having bowel cancer and offer them a colonoscopy rapidly, versus the people with a very low risk of colorectal cancer who can be managed in other ways, has again been something we've been using to try and improve our productivity and the effectiveness of our diagnostic services. And a variety of other areas of innovation also coming in to try and, as I say, drive up the productivity, using new technologies such as circulating DNA, which we can pick up in the circulation of people with lung cancers, and potentially use this as an alternative means of diagnosis, looking at the molecular abnormalities in the DNA in the circulation in those people where it's difficult to get a biopsy and it's time consuming to get the molecular results back. By using circulating DNA in a pilot which we're expanding to 10,000 people this year, we have been able to significantly telescope the time to diagnosis and thereby streamline the process and make much better use of the resources that we have at our disposal. So a number of things, and the paper lists others, where we are trying to more efficiently help people who present with symptoms who are referred into the system to alleviate some of the pressures. For people without symptoms, the screening programs, we need to maximize the effectiveness of our programs in breast, cervical and colorectal cancer, as has already been alluded to. In breast cancer, that's primarily about driving up uptake, which has diminished progressively and diminished significantly during the pandemic. So to try and make sure that we can bring people in and restore their confidence in the breast screening system. Cervical cancer screening is hovering and is close to where we want it to be, but with some extra effort. And I think the self-sampling opportunities that we can see for people who find it difficult to have a smear for whatever reason is a big opportunity. And in colon cancer, fecal immunochemical testing has been very successful, and people will have seen the public information campaigns that we've run to try and encourage people to return their fecal immunochemical testing, blood in poo for short, tests, which has driven uptake progressively upwards in a linear way over the last couple of years. There are some innovations on the horizon in this area as well, and people will have seen the work we've been doing to test the possibility of multi-cancer detection tests, again using the technology of circulating DNA to see whether it may be possible in an asymptomatic population at risk of cancer in their 50s, 60s and early 70s to increase uptake. And we've literally just concluded last week the 3 years of annual blood testing in a very large randomized trial, which included 140,000 people who we recruited 3 years ago in the middle of COVID, over a 9-month period, whereby they have an annual blood test, and we are analysing that to see whether we can pick up early cancer signals in half of them, and the other half is the control group. And we will see the results of that in late 2025, early 2026, and then be able to make a judgment as to whether this will help us to find more asymptomatic cancer. The net result of this activity, notwithstanding the pressures on the system and the challenges and the difficulties of increased waiting times for diagnostics, is that we have in the last 2 years seen a progressive raise in the rate of early diagnosis of cancer. Since we've been recording this, it's been hovering at about 55 or 56%. And in the last 2 years, for the first time ever, we've recorded an uptick of 2% in the early diagnosis rate, the proportion of people whose cancers are diagnosed at stage 1 or 2. That is clearly a long way from where our ambition is, which is that 75% of people should be diagnosed at an early stage. But nonetheless, it's an encouraging sign initially that all this running the system very hot in order to diagnose cancers is starting to pay off. And really importantly, the experience of people diagnosed with cancer continues to be reported relatively positively. Our cancer patient experience survey, which we send out to around 120,000 people each year, and we get a rate of return of about 50%. We've just seen this year's figures, and in general terms, the level of satisfaction for people diagnosed with cancer with the service they receive is holding it at a high level. I think it's 8.89 out of 10, which in terms of the sort of things you see in the commercial sector is really very high, and the majority of our indicators have improved over the last year. The notable one which got worse was that fewer people felt that the length of time they were waiting for tests felt that was reasonable, down from 78.4% of people who thought it was reasonable last year to 77.6% of people who felt it was reasonable this year. So even where we're not doing as well as we should, and where we have big pressures in the system, in general, the levels of the people's experience of their care is very good. But we do recognise, particularly in the time it takes us to go from a diagnosis to initiating treatment, that we have a significant amount of work to do on that. And the implication of that, I fear, is that the proportion of diagnostic activity occupied by diagnosing or ruling out cancer is likely to need to rise over the next 2 or 3 years.
Thank you. So I'm going to pause and see if people have comments or questions. So Andrew, I know you want to come.
So really fantastic progress on the diagnostic part of the whole pathway. But Peter, are there particular constraints on hitting the 62-day standard? Is it theatre time, consultant time, diagnostics, or is it a combination of things? Are there just one or two things that in most organisations are the limiting factors?
And hold, see if there are other comments or questions, Peter. I mean, I would ask them, I don't know, it's a real layman's question when you talk about innovation, but I would say as I look at that, I agree with the thrust of Andrew's question, actually, which is there's wonderful progress, but actually there's still very high proportions, high percentages of people who are not getting treatment started in the anywhere near our constitutional targets, actually. So that we have to acknowledge that, and we do our best to try and hit it. But just it's on the innovation. It's a combination of the cancer vaccine launchpad and that. I think it was called a personalised cancer vaccine given to that gentleman in Birmingham, who I think had bowel. You'll have to correct me. Had bowel cancer, and it was a post the surgery and other interventions, I think, vaccination, and it's the prospect of potentially a fourth armament with which to fight cancer: surgery, chemo, radiotherapy. Is it silly of me to think there might be a fourth armament that can operate at real scale, which would be, I'll call it bespoke vaccination, personalised vaccinations, and particularly for, I'll call them the higher volume cancers. And the other innovation, which I do think is really potentially quite exciting for briefings I've had, is the liquid biopsies ability actually to identify, and you did allude to it actually, in terms of a different way to identify cancer within populations. So those would be mine. Do you want any other comments or questions for Peter before, or for David? So do you want to pick up Andrew's question and my comment?
So the interval between referral and initiating treatment, if we look at where the challenges lie, in rough proportion, about 3/4 of the challenge is in diagnostic times. And when we saw the times, as we've seen the times going out over the last decade, as I say, happily stabilised now and starting to turn around, but the majority of the deficit has been in time to diagnosis. So that's people getting a scan, people having a biopsy, waiting for the result to come back. That's about 3/4 of what we've needed to solve. And that's one reason why I think the ability to hit the faster diagnosis standard is going to be so important, because what that speaks to is the timeliness of investigations and making use of the investment in diagnostic capacity. There are still some significant bottlenecks. I'm quite anxious about cellular pathology and our ability to recruit sufficient numbers of histopathologists who are the people who actually make the diagnosis. But that's where most of the deficit lies. There is about 1/4 of it which is timely access to treatment, and of that the biggest determinant is cancer surgery, because most initial treatment for cancer is surgical. And there that's about access to theatre capacity. And what we see is that as we address the elective waiting times pressures and we increase the number of elective surgical operations, so it's much more difficult to flex the ability to increase cancer surgery in response. So every time we focus on elective recovery, we see the cancer surgical waiting times getting a bit worse. So there are pressures in cancer surgery. We are investing heavily in things like robotic technology, which are very good for driving down length of stay, improving the patient experience, reducing morbidity post-operatively, and something like 95% of prostate cancer operations are now carried out robotically, and we will see this spread into other areas. But access to theatres and the ability to get our surgeons operating as much as they would like to, you can almost never get a surgeon operating as much as they would like to because that's what they do. But we do have a workforce in cancer surgery who are probably not getting as much theatre time as they would wish, and that is undoubtedly constraining our productivity.
And I know Robert, I think, wanted to ask a question, make a point, and then Mark, and then we'll probably need to move on to the next item.
Quick one, Peter. It's a really helpful update and some great progress. You mentioned histopathology as something of a bottleneck. What's the state of play in terms of digital pathology linked to AI in interpreting histology?
Again, digital pathology is an area in which we've invested very substantially over the last few years. There is a very large amount of digital pathology kit now in our hospitals. And what we are working hard on doing is the implementation plan, and this sits mostly with my colleagues in the diagnostic part of the operation. But there is a real push to implement this, and we are seeing more and more trusts going fully digital, which has enormous advantages because it means that you can move the work around the pathology networks and you're not reliant on the site-specific expertise in one specific hospital. You can move it. There is a challenge, as with all things digital and IT, to make sure that we've got genuine interoperability and scalability for these systems. But actually, I'm optimistic about that, and it's an area where we're pushing very hard. To return to your question about the immune system, the cancer vaccine area is primarily aimed at the adjuvant treatment, the post-operative treatment of people who've had a resection of a tumour where there's a risk of recurrence from residual cells, and the ability to generate a vaccine which will drive the immune system to recognise those, which is an area where what we're anxious to do is make sure we accelerate the research as briskly as possible. And I'm glad to say that the trial that we've started with, which is a trial in the adjuvant treatment of colorectal cancer, the UK is now leading in international recruitment. This trial is running in the United States, Germany, Spain, and having put this system in place, we are now leading the recruitment in that, and we've got more trials coming through as a consequence of that, which I think is going to be very important for our patients. The whole area of immune treatment for cancer is one where there's been a progressive expansion over the last few years, and that will continue. For example, people with mismatch repair deficient colorectal cancers now, if you treat them with an immune-stimulating antibody preoperatively, in a proportion of cases, there is no tumour left by the time they come to operation. So the landscape of how we manage many of these tumours is likely to change as a consequence of this.
Thank you. I'm going to pick up. So Mark, I think, was going to.
Robert's essentially asked my question. It's fine.
And Julian, you want to ask to make.
Can I just follow up your answer to Robert's question? And I've got one other. Follow up your answer to Robert's question. You said there's a lot of kit. People are beginning to use it, but like Peter, you wander around a lot. Is the investment at this point paying off, or have we got to go back round and really make sure that it is paying off? And my second question is, when you look ahead 2 or 3 years for the innovation rounds that we have run, what do you honestly think is the most promising thing that is going to sort of come into sort of real use, delivery, whatever the phrase is, over the next 3 or 4 years?
So in terms of digital pathology specifically, I think the capital investment has been effective. I think the ongoing costs of implementation and running it is something which provider organisations are still working out. And for example, the cost of storage of digital images is something that people are wrestling with. And I think the kind of project management implementation capabilities within the providers is something which is quite challenging. They're trying to put in new laboratory information management systems at the same time as going digital, at the same time as delivering the workforce expansions they need. But I do see in the diagnostics team a real push to get this done, and every week I hear about another large provider that's gone fully digital, and that is moving forward, I think, quite well. In terms of the innovations that we're funding, we've got a slew that are in development. I think, for example, the cytosponge, that swallowable device where you have a pill on a string which has a sponge within a capsule. You swallow it and the capsule pops inside the stomach, and you can pull the sponge back out and examine the cells lining the esophagus in doing so. Has, where we've implemented it for taking the pressure off the upper GI endoscopy waiting lists, proved highly effective. Not for the primary diagnosis of cancer, because I think you still need an endoscopy for that, but for example, people who've got heartburn and changes and pre-malignant changes in the esophagus which need monitoring, they have a lot of endoscopies, but we can probably substitute those in large part with this kind of investigation. So I think there are diagnostic techniques and devices coming through which will help us to become more productive and to help to manage this progressively increasing burden.
Peter, I think we could go on for quite a long time on hearing you on the topic of cancer and innovation, and also actually our performance. But I am conscious of time for the board meeting, so just say thank you very much for that. I mean, David, did you want to comment at all? I mean, it's slightly unfair to throw you a ball with that particular question, but you're a key part of it.
Well, the one thing I sometimes get accused of in as we talk about these national numbers and national percentages, is we lose sight of the patient in this sometimes. And actually, what I think is really important to remember is that 2.4 percentage point increase we've seen in early diagnosis may seem modest, but actually that's 7,000 or so more people each year being diagnosed at stage 1 and 2, as opposed to stage 3 and 4, with all the opportunity for curative treatment that goes with that. So it really matters to the people in our care. Yeah, and that's nothing we've done. That's staff across the NHS.
Small percentages can hide large numbers, actually. So, David, thank you. So let's move on. Steve, I'm going to ask you to try and help here. And just when the board looks at the agenda, we're going to slightly shift it around. So what we're going to do, we're going to take item 7 and item 9. So welcome, Jane. So we have Dr. Jane Chidgey-Clark here, the National Guardian. And actually what we're going to do, Jane, is start, if that's right with you, but actually then in parallel or alongside it, actually bring up item 9, which is our own Freedom to Speak Up annual report, and to have our Freedom to Speak Up Guardian's reflections on that. Steve, if you can help coordinate, and then actually I'm going to move, if that's okay for Habib and Bola, I'm going to move the health inequalities to be that item after those, but I'm putting the Freedom to Speak Up and National Guardian's items together. Okay.
Thank you, Richard. As the board knows, at the heart of everything the NHS does, indeed we do at NHS England, is that ambition, that constant striving for the highest quality care and the highest quality services for our patients and citizens. A really important component of that is keeping patients safe and ensuring that we do not inadvertently cause harm as we are caring for patients. And in turn, a key component of that is ensuring that we learn when things do go wrong, and of course in the vast majority of times they go right, but occasionally they go wrong, and occasionally we can see where there are services that are at risk of issues arising and things going wrong. There are many ways in which we do that. Incident reporting, which is now well established, use of data through audit and registry programs, for example, but the freedom to speak up processes and culture is a really critical part of that learning too. And so today we have 2 papers, as you say, on freedom to speak up, and I'm grateful that we're taking them together. We've got the first report from Jane, the National Guardian. Welcome from me as well, Jane. NHS England and the CQC jointly fund and sponsor the National Guardian's office. And as part of that, the National Guardian comes every year to report. It's not the annual report of the National Guardian as laid before Parliament, but it is a report to the board of NHS England on the work of the National Guardian. And then we also have a second paper which is our own report on our own freedom to speak up processes within NHS England as an organisation. I'll say a few more words of introduction specifically to that paper when we come to it. And I'm happy, Richard, to take discussion of both papers at the end or each paper after each other. I'll leave that to you. But before I hand over to Jane for the first paper, of course, it's really important to note that freedom to speak up is not just about the process, it's not just about the guardians, it's actually about the culture. And it's about the role that particularly leadership within the NHS, but not just leadership, has in creating a culture where people feel enabled to and empowered to speak up, and in which the organisation is in listening mode and responds to that speaking up. And as the National Guardian's website says so plainly, it's about speaking up about anything that gets in the way of doing a great job, and freedom to speak up guardians support workers to speak up when they feel that they're able to do so in other ways. And with that, I'll hand over to Jane for her annual report to us. Jane.
Thank you very much, Stephen. Thank you very much, Chair, for the invite. I can't believe it's a year since I was last here. Where's it gone? And it is really important to have this opportunity to speak to you both as our funder, but also as a key partner in the work that we do, because as the National Guardian's Office and as your National Guardian, I can't do this work alone. So I really appreciate the opportunity to come and talk with the board about what we've been doing, what we're planning on doing, hearing your thoughts and reflections, and also an opportunity to thank your teams, particularly Navina's team, who we work closely with this work that we're doing. So I don't intend to go through the paper in detail. I'm happy to take questions or comments on any parts of it, but there's a few key highlights I'd like to pull out. First off, just on governance, this is actually a formal requirement that I come here underneath our Department of Health and Social Care and CQC governance framework. I come to you once a year, go to CQC once a year, and also to CQC's Governance and Audit Committee, as well as our own independently chaired Accountability and Liaison Board, on which Sir Andrew sits and one of Navina's directors sits, along with CQC directors and the DH. So that's our governance. But what's really important to talk to you about is the work that we've been doing this year, and really give you a reflection on some of the challenges that we face, because I think we're at a time, I said it last year, I was really worried. I remain really worried, and I think we should all remain really worried about the extent that there is still to do for changing the culture for better in NHS organisations, and from my perspective wider for those organisations that look after people with NHS funding. So you'll see in the report I start off by just talking about our strategy. We published a refresh strategy this month. It was due to be published just before the election, but because of pre-election period we couldn't. There'll be nothing brand new in there for you. It just focuses for us as an organisation our work plan for the next 3 to 5 years, our priorities. We've done it in conjunction with our key stakeholders, and that will help frame our work, and underpinning it sits a really important year-on-year business plan and initiatives that we will be responding to. What's really important in that strategy is a change of focus in our terminology from people feeling safe to speak up to people feeling confident to speak up. And that felt really important to our stakeholders as well as ourselves, because in order to be confident, you have to know that something's going to be done. And I think that's part of, we talk about the barriers of a good open culture as being the two biggest, being fear. Something bad's going to happen if I put my head above the parapet and make a suggestion for improvement, or point out something that may be a risk to a patient or to a colleague. And then alongside that, it's the futility. Why bother? I've spoken up, nothing's been done. And that's what Sir Robert was envisaging when he introduced or suggested the introduction of a new role. The role not to replace the existing routes for speaking up, because ideally we should all be able to talk to our line manager. We should all be able to talk, within our existing structures, but we know for different reasons people can't. So that's what the additional safety route of having a guardian in an organisation. But when I talk about speak-up culture, yes, we need to get the guardian routes right. And, I'm really interested, and I'm glad you've put your paper on the same day as I'm here to hear that and see that. But actually what we need from organisations is to be thinking about the wider culture. How are we supporting our managers in speaking up? How are we supporting them to do the right thing when people do speak up to them, not just when it comes to the Guardian route? Because in effect, stuff coming through the Guardian route is a bit of a failure of those other processes. So we need that overarching, and that's I'm speaking to you as a board for your employees as well as you leading the NHS organisations out there. So that said, I've included highlights of progress of what we've been up to in the last year. We do have now over 1,200 trained and registered guardians, which is a year-on-year increase, both within, obviously all NHS trusts are mandated to through the contract, but in addition we have ICBs, we have private providers, we have national bodies like yourselves, and we have primary care increasingly uptaking using guardian services. More on that in a minute. What's really interesting is that other sectors outside of health are coming to us to say, let's learn about this NHS model. And I think that's really encouraging that people are seeing there are some benefits here. Obviously, we believe there are benefits in what we're seeing, and wanting to look at that. And we're sharing that practice with them through a very vibrant pan-sector network. But, you know, I've had conversations with Cabinet Office, with some of the blue light services, with education. This work is for all organisations. We all need to get our culture right. So it's really important. Last week, and I'm sorry the link to the report aren't in your report because of your timing of getting papers in, but if you're interested in, and I hope you will all individually be interested in looking at the two really important reports we've produced last week and this week. The first is on annual data, so we collect anonymised data from all the guardians. And when we look at that data, there's a 27% increase in cases reported through the Guardian route. Now, on the one hand, that's a good thing, because at least they're bringing them to there, because they might not be going anywhere else in organisations. And then when we think about the significant number that will be patient safety ones, and I don't just mean those coded as patient safety issues, because actually the worker well-being and worker safety issues, the bullying, harassment, victimisation, we know they have a direct impact on patient safety. We've seen the evidence of that, both in the UK and internationally. So in effect, the majority of those cases are going to have patient safety implications. So am I concerned that there's a rise? I am and I'm not. I am in the sense of what's wrong with those other routes, that they're not working well enough, that we're seeing an increase. But on the other hand, I'm glad that they're going to the Guardian, because that's, you know, 37,000 opportunities to listen, learn and improve and potentially prevent harm in the future. So that's, I think, key headlines for that. The other headline to share with you is the 4% that's the same as last year, the 4% of cases that are still being reported to guardians as feeling the person speaking up feels they've suffered detriment for doing so. We've seen that in some high-profile cases going through employment tribunals and in the media, and clearly that's something that through the work that you're leading, through the leadership capability framework, we have to tackle as a system to ensure that leaders and managers are not allowing detriment to happen for doing the right thing, which is what speaking up is. So that figure, and talking your point, David, about small percentages, what's that in real numbers? That's over 1,500 individuals, and that's the one using the Guardian route. How about those that are suffering detriment for speaking up to their line manager or going to HR or going to you know, the patient safety team? So it is a significant issue, this issue of detriment. If I just come to the NHS staff survey, so you publish your staff survey in the year, we published yesterday our analysis of the speaking up component of it. Key headlines for that is another warning call to us all, and that's that the clinical practice questions are showing a decline. So do I feel safe speaking up about clinical concerns and feeling that it's a 5-year all-time low? 3 out of 10 people don't feel who answered the staff survey, and that's, we don't know those who didn't answer the staff survey. So we have absolutely no room for complacency, and so the work that you're doing, that we're doing, the important work of CQC in their regulation of well-led, and really importantly the work of individual organisations to really engage, and I think you used the word earlier about engaging our workforce, Steve, is absolutely key, because if we don't engage really meaningfully, and that's not just having a policy, adopting the national policy and having a guardian, but if we don't engage through staff forums, if we don't engage through our line management structures and meetings, then people aren't going to come to us and tell us what we need to know. So really important. Overall, the score is stable, but that's hiding the fact that the clinical concerns are decreasing, and we need to see that shifting the dial on that in a more positive perspective. I then talk about some of the other work. The work of the Ambulance Trust Review that we did resulted in NHS England being commissioned to carry out their more wider reaching cultural review into ambulance trusts, which I'm sure you've regularly heard about, and that ongoing work is really important, never the more so from what was on Sky News yesterday, Steve, that you commented on in terms of the ongoing concerns around sexual safety, but it's much wider than that. In terms of that Speak Up review obviously concluded, but we're continuing the work with making sure the recommendations become embedded. We've commenced our second one, and that's on the theme of overseas trained workers. We know from local as well as international research that those who are of our colleagues, of which there are so many valuable in the NHS, we know they have a more difficult time speaking up and also on the response to speaking up. So we're wanting to do the deep dive into that. We're working closely with NHS England colleagues because I know you're doing lots of work in that area as well, but we hope it will give value added, and we can come up with some recommendations that will help organisations in considering particular needs of overseas trained workers when it comes to thinking about the cultural differences. And we might say we've got a great freedom to speak up policy, come and talk to us, but if I don't come from a culture where that is acceptable or deemed respectful, then we're on a hiding to nothing to start. So some really important work to consider there. And we'll be publishing that hopefully by the end of this year. Work is well underway now. I've highlighted a section that talks about our partnership working. I've alluded to some of it with yourselves, but it's with others as well. And particularly another one that's been of import with yourselves, and that's the work that Sir Andrew co-chaired with ourselves following the Lucy Letby trial and announcements, whereby we were commissioned to look at escalation routes for serious matters of concern. And that work is ongoing, and it's a really important piece of work to conclude, because we do need everybody out there in the system to know how they can escalate if they don't feel internally that their concerns are being taken seriously. And I think it's really important to say that I know from the board visits that I've done in multiple organisations, guardians I've spoken to, and following the letters that you sent out, I know that organisations are asking themselves those uncomfortable questions, could this happen here? And it's really important that we continue to ask ourselves those questions, because that's why it's so important that people can tell us and will act on it if they do. I noted that I went to the Health and Social Care Committee and took part in the inquiry into the NHS leadership performance and patient safety inquiry, and I wanted to highlight a particular comment that I made there at that committee, and that's I feel the importance that needs to come from the top, and from the top I mean from DH and from government as well as from yourselves, around the importance of finance and performance. Yes, there's a lot of discussion about that today, but actually culture needs to be that third arm. And I know at local level that quality discussion is very apparent, but it's a quality discussion. I don't think it always goes wider to be that wider cultural discussion. And I'd like to see that as a bit of a change, because we know what we measure and what we focus on gets the attention, and I think we need to set some example in saying this is really important, that we look at this in a greater depth with equal weighting to finance and performance, because we know we're not going to have best performance and we're not going to use our finances best if we don't have great culture. The work with primary medical services and integrated care systems is really important. The Guardian model has been well established now in NHS trusts, but it has other challenges within primary medical services, and we're working closely with your teams on that. We don't have all the answers for that yet, but it is very important, and particularly understanding the role of ICBs in that. ICBs are looking forward to greater clarity on their role and their jurisdiction in that space, so it's an important piece of work that we are looking forward to continuing with you. I've included in my report some discussion around what we're doing to improve our support for guardians, their training and compliance issues, and also further development of their roles. I'm happy to take any questions on that. On the compliance note, we've realised that what's really important is that we give information back to the regulators if organisations are non-compliant, either by having a guardian's not trained and registered with us, or if they're not submitting data, because these are key requirements that you've put in the NHS contract, and we worry that if those organisations aren't investing the time in their guardian service to be able to do those things. So if we hear or we see that a guardian is not submitting data or an organisation doesn't have one, I will write to them and ask, what's happening? Can we help you with this? If I'm not going to get anywhere with that, then I will be escalating to yourselves and CQC and looking for some support in that compliance, because it's either important or it isn't. And I think that's really important. And quite often it's not because a guardian isn't submitting data because they're not performing. It quite often is because the guardian hasn't been given adequate time to carry out the role. We still see a big disparity in how the guardian role is implemented, and some boards and some organisations are not putting enough resource into that role to enable it to actually do its both proactive and reactive components. So we'll be looking for further guidance for that later this year. Section on some of the comms and engagement that we've been doing, and really just out of my conclusions, what I just want to highlight to you is that there's a lot of work to do. There's absolutely no complacency from me and my very small office, but what's really important is that we continue to work with yourself as a regulator, with CQC and with our system partners, because all of us can't afford not to. This is too important to issue. We saw what happens when it goes horribly wrong. And I know we're all waiting for the results of the third wall inquiry, but in the meantime, we know we need to increase the focus on improving culture, because without it, I think Megan Wrights is a researcher in this field of psychological safety and speaking up, and she talks the missing voices, the risk of missing voices is careers, relationships, and ultimately lives. That's the stakes we're talking about. So I hope my report's been helpful. Happy to take any questions or comments. And thank you very much.
So, Jane, thank you. I mean, that was really a very cogent and thoughtful presentation of the key issues from your report, both historically what you're seeing and also looking forward, some of the aspects that you're clearly further focused on. What I'd like to do, if I can hold the board back for a moment, I think I would actually like, if possible, Steve, to bring in Dorota and Annalise, if possible. But Steve, you want to say anything
so a few introductory...
We'll bring in the NHS England FTSE Guardian's annual report. That's okay.
So a few introductory words for me. So the first thing is that this is our annual report covering 2023 to 24. It is a period where Richard Barker, you heard at the start of the meeting, has recently stepped down and retired from being the regional director for the North East and Yorkshire, was the executive lead and sponsor for the Freedom to Speak Up programme. So just to acknowledge all the leadership that Richard has given to the programme over the last year. He has now handed over to me as of this month. It is a role that I have performed before. I last did this 5 years ago. And actually coming into it in the early handover, I'm just struck by some of the similarities. As in 5 years ago, we have just come through a period where another organisation, another two organisations have come in, and so a lot of work has been done. I'm glad to say that the unified service, as a result of the recent bringing in of HE and NHS Digital, has gone live in June. So similar challenges as the last time when we brought NHS Improvement in, but I can also see how progress has been made. And it's clear to me, and you said, Jane, at the end, much has been done, and I can see the work that has been done within the team since I was last responsible. But there is clearly still much to do, and that's highlighted in the report. So just a few things to highlight. So in the last year, there's been a real focus on a number of things, on working closely with HR and ensuring there's an alignment between the Freedom to Speak Up processes and HR processes. There is an interface. It's important to ensure that they're aligned. There's been work that I know that's been going on with the board and executive team about how we can support the Guardians as a senior leadership cadre better. That is always challenging. Time is always precious, but it is important that the leadership of the organisation engages regularly with our Guardians. There's a number of ways in which we've been doing that, but we could always do better. And I'm glad to say that the Guardians are working with the Freedom to Speak Up team closely with on our new people plan, because we are still hearing, again through our staff survey, that there are barriers to speaking up, that some of the themes around behaviours and leadership still come up. And it's important that we take the learning that the Guardians have into our work on the organisation and the plan for the new organisation. But it's really important that we, in the spirit of listening, that we bring our guardians to this so that the board can hear directly. So we have Annalisa and Dorota, who are two of our guardians, and it's their opportunity to speak directly to us as a board. I think, Annalisa, you're going to go first, but let me hand over to you at the end of the table.
Thank you very much. So just some reflections on cases that I've managed. I think the complexity of them is increasing. I think that the handover between freedom to speak up and HR can be often quite complex, and indeed navigating that in supporting the individual to understand that complexity, especially where we might get, in some circumstances, counter-allegations made, which makes that very complex. And keeping sight of freedom to speak up in that process is tricky. Keeping people physically and mentally well and capable still to function is a real challenge, and I think that's something that we really strongly focus on in freedom to speak up. Obviously linking in with the various relevant elements of support networks we have in place. Confidentiality, I think, is a little bit of a challenge, and what I mean by that is when an individual may have spoken up about a senior person in their team or their directorate, and indeed the challenge then when the rumour mill starts within the team, actually managing that and keeping the person safe in that situation could be a challenge. Also enabling, I think, our very busy directors to be able to have the space and time to reflect on some of this, learning some of the space to grow and actually heal in a respect from the team, as a team, when they come across some really tricky challenges. Lastly, Chair, what I would like to say is we've spent an awful long time in the beginning part of the meeting hearing all of the challenges that go on and indeed the complexity that we have to manage as an NHS. And indeed, I'd like to say thank you to Amanda and indeed the NEDs, because I appreciate how busy you are, but what you do is take the time to actually listen to us and come and hear our voices. And you truly listen in that space. And so thank you to the NEDs and indeed Amanda and the NGO for all the support you provide us. Thank you.
Well, thank you very much. I mean, you're making some very strong points more broadly about the difficulty in handling particular cases and so on. But thank you for your last remark. And I just say actually to Andrew, who's our lead for the non-executives in that sort of relationship with our guardians. But we've also met with you. I think a number of us have met with you very frequently. All of the NEDs actually at various occasions have met with the guardians, and it's been really helpful to hear your voices directly. But Dorota, now would you like to come in at this stage? You should.
Perfect. Thank you very much. So Dorota Mason, I'm a Freedom to Speak Up Guardian, and thank you for inviting me today to this board meeting. So the information I shall be sharing with you relates to grievance cases I have supported in relation to bullying and harassment. It is really positive to hear, I need to emphasise this, through the papers that have been shared, that we're creating an employee relations team, a mediation service and a resolution framework. It's really key that guardians feed into these areas. Mm-hmm. I believe, and I also speak on behalf of my reporters, that we cannot forget 5 key needs as part of this work. So, number 1, to produce a comprehensive grievance policy and procedure. Number 2, agree timeframes for processes. Number 3, strive to produce quality investigation and outcome reports. 4, agree touch points with reporters. And number 5, follow through on recommendations. By doing that, this shows commitment and continuous improvement that we are actually listening and are being a responsive organisation. These 5 points that I've referred to are important because it really impacts staff and this organisation. We know that without these elements, this can increase to prolonged stress, it results in a negative speaking up experience. It can lead to sickness levels rising. Talent also leaves the organisation and our workplace culture is weakened. I think we also need to remember that nobody wishes to raise a grievance. We therefore need to act early, continue striving to be an excellent organisation, and we need to care for our workforce because our workforce is our greatest asset and we need to support it. Thank you for listening.
Thank you. I'm going to give a few minutes for people to react or just ask questions. React or ask questions, either of the NGO, Jane, and or Annalise, you or Dorota. We're going to try and gather them because I've failed to run the agenda appropriately. We've got a very important item we still haven't done, dealt with or heard, and Chris and Habib and Bola, we really need to hear you on inequalities. So I'm going to try and gather them quite quickly, just from around the table. I do remember, though, the last call we were on together with Andrew a couple of weeks ago, and that point about timely resolution because of the strain that carries on for the individual if we're not. And I realise complexity sometimes mean, these things are not instantaneous and they will take time, but sometimes some of those times to address have struck us as quite long in that conversation we had a couple of weeks ago. So let's just go around and gather. So Amanda's hand.
And Andrew wants to come in.
Well, Andrew should definitely also speak because you both engaged. So I've got Mary, Amanda, Andrew. Should we do that? Mary, do you want to go first quickly?
Just very quickly, I wanted to say thank you for such great presentations and also for the fact that Jane gave me a tutorial on this recently, which was very helpful for me to get the national picture. I just wanted to ask whether, as you've got independent providers getting involved, whether all independent providers that we place NHS patients in, and I'm particularly thinking about mental health patients, have this kind of structure, and if not, whether in future that might be a criteria for placing contracts.
So it's a normal trick. I mean, you may have to take notes as to who might want to answer that. I think that Jane might have been aimed at you. So Jane, and then Amanda.
Oh yeah, look, just very quickly, just to say thank you. I mean, I'm relatively new non-executive director, and I've found the conversations that I've been part of over the last few months really helpful and insightful. So thank you so much for what you do. There was a particularly thoughtful discussion, I thought, which Richard just alluded to it on the last call, about the interaction between sort of thoroughness of investigation and length of resolution. Mm-hmm. And the stresses and strains that come with that. And I was particularly interested in the discussion, which is alluded to in the paper as well, but about the role of mediation and how we perhaps boost that. And I look forward to returning to that theme in future discussions.
Thank you, Jane. So Amanda, do you want to?
Thank you. It's a question. So again, it was just to say, start by saying thank you both to Jane, but also to Dorota and to Annalise, because I think what you have made us do is really stop and listen, which is the job that you do so brilliantly. But also stop doing your finger tapping, Richard.
Actually, it wasn't about your question, which was very good, actually.
You haven't heard my question. But what I think is, if I reflect on NHS England, the truth is we have not made it easy for you to do your jobs. Not only have we done what we've discussed earlier about bringing 3 organisations into one, the complexity of the inheritance of some of the cases that we've got, the complexity, as you've already said, of the interaction with HR and some of the speak up cases. I really want to commend the Guardians because you've shown extraordinary resilience and frankly patience with us to keep going with this, and I'm delighted that things are beginning to move forward. But I'm really struck, Jane, by your point earlier on, which I think is just true, which is what we measure matters. So we're doing a lot internally. Steve is leading, looking at our kind of, if you like, our corporate health, so that we review regularly. I mean, it's everything from, what our vacancy rates are like through to our sickness levels, grievances, speak up cases. My question is, what one thing would you want us to be looking at internally as a way of making sure that this gets the right kind of focus going forward. And again, I'm really struck by it's the detail, some of this, it's the 5 steps. We talked before this meeting about our response to our own internal staff survey and the 6 big commitments that we're making on that. But again, it's like it's 6, it's 5, it's, you know, it's how do we make sure we're looking not lost in so much detail that we sort of, you know, miss the wood for the trees, but that we are focusing on asking the right questions of ourselves. And Jane, it's my same question to you. You know, if again, I know the answer won't be just one thing, but what one thing would you be saying to us? We've just done a piece of work consulting on a new oversight framework for the NHS, which is trying to be much more balanced in pulling in data, and admittedly it is mostly hard data, but data that gives a much more rounded view of everything from patient experience to outcomes to staff experience outcomes, etc. But what would your ask be of us around this agenda and the point you've made so powerfully about culture?
Well, okay, Andrew.
So just building on that,
I'm going to just so you know, I'm going to go Andrew and Tanuj, and then I'm going to refuse to catch anybody else's eyes to enable you to answer and to then move on to the very important next topic. So, Andrew and Tanuj.
We have brought 4 organisations into one, and Amanda was very clear at the onset. This was about creating a new and different culture, and I think the Guardians are absolutely full on in terms of understanding the commitment that exists from all of the exec team to try and get Speak Up into a better place. However, the one thing that always comes across in any conversation we have with the Guardians as a group of non-execs is it's the first line manager bit. Yeah. And are we tooling up those people appropriately to act, listen and resolve matters at the lowest possible operational level? And I think that's our challenge going forward, because it comes up in every conversation that we have with Guardians.
Thank you for it. Great program and great. I just 2 very precise set of questions, Jane, for you. One was the 1,200 plus trained Guardians. Any sense on what's the demographic profile of that group and how closely or not does it reflect the demographics of the workforce, and does that even matter? I think that's the first question. The second one is, I note the 27% increase in cases, and as you rightly said in your briefing, it can be a really good thing. You know, it's a reflective of the confidence of people growing up. But seeing what you see, the big picture, what is your takeaway on, is it increased confidence that the cases are going up, or do you see a sense of a deterioration in the conduct environment or culture? So any sort of colour on that would be useful, but really great update. Thank you.
So can I very quickly, Jane, do you want to take the specifics to you first, and then Dorota and Annalise, if you wanted to react to the comments made, that would be good. So Jane?
Certainly. So in terms of the demographics of the Guardian population, really great question. In our report that we do when we look at Guardians and we do a Guardian survey, I don't have the figures right to hand now, but I can circulate that for you after from the last one. But no, they're not reflective, and we encourage organisations to, when they're recruiting, as with all recruitment, to look at that demographic and to really try and positively recruit to reflect the broad the broad range of workers that there is. So it's a no and it's a yes, and we need to do more with that. The second, in terms of that increased figures, what's my take on that? My take on that is, if I look at it in conjunction with the staff survey, it's not that great news. It's good that they're coming to the Guardians, but with the decreased confidence, and obviously the staff survey asks about just speaking up to any route, so it's not just talking about the Guardian route. What it's saying is we're not as confident as we were, and so therefore people are obviously. So I think it's not a good news story. We need to do more. And may I just quickly answer Amanda's question of the one thing? It's actually going to be 2 wrapped up in one, which is naughty, but there isn't just one thing. I've got a shopping list for you. I think it's that whole point about measurement, and you as a regulator and as the leadership of the NHS setting that tone for what's measured, what you measure, but also what you're asking of others to report on around their culture and their improvement plans, and more looking at the compliance, because that links in with the question about private sector. And if I can quickly answer that, and then I'll shut up. In terms of anybody providing NHS services under the NHS contract should have a guardian and be looking at their culture. But again, that comes back to what's the compliance on that. CQC, when they're doing their well-led inspections, should look at that. But in terms of capacity and that whole compliance piece from your perspectives, I think that we've got more to do on that.
Thank you very much. And Annalise or Dorota, do you want to react at all to any of the points made?
Thank you very much. So I think my one thing, it's going to be really daft to say, I think we need to be more humanistic in our approach and indeed enable our policies, processes and procedures to be a lot more humanistic in navigating some of these challenges we face. I think that's probably my biggest reflection. I think we have situations where, for instance, one case where we have 10 people speaking up about a senior person in a team, yet because everybody feels so unsafe to be able to step into the space to say, I will stand against a grievance. We're disabled almost to be able to push something forward. So I think it's being more humanistic and enabling our policies, processes and procedures to actually act on things. It's time for change on our policies, I feel.
Right.
Thank you very much.
Thank you.
So,
May I go?
Your one thing.
I would say, and we've done some work around this, so I need to caveat this, is that we need to equip line managers and staff with the skills, and I say staff as well, moving forward, because it's very difficult having these difficult conversations. It is a real skill. I'm not quite sure whether an e-learning module covers this or whether an hour's training session. I'm going to go back to the days where we used to take out a full day and it was interactive. And I know people don't wish to do that sometimes, but it is actually super helpful. So I think we just need that commitment to support our staff in relation to behaviours, how we listen, how we take that information in, and what do we do with that information. And I'm going to be really cheeky and follow Jane, and I'm going to say the other point is that if we do not have enough staff to support some of these mechanisms and processes, then potentially outsource the panel, potentially outsource the investigating officers as well.
Thank you very much. So I'm going to thank Jane for...
May I just endorse that, the work, and I think, again, the work that we need to do for preparing managers to be good managers, and that's across the NHS, is absolutely essential. It is for leaders, and we know that works in train, but I think the management piece, we're not born managers, we have to learn usually by our mistakes. So I really endorse that. Thank you.
So Jane, can I thank you, and can I also thank Annalise, you and Dorota for your contribution and the discussion, and Steve, thank you very much for taking this on, and Andrew, as always, thank you on behalf of the NEDs for acting as the lead NED with regard to FTSE Guardians and all the feedback and so on. So thank you. It was a very good conversation. We're going to go to the last substantive item. I'm going to apologise and say we're going to go a few minutes over, probably 5, 6, 7 minutes over the scheduled time. So my apologies for that. I do know one or two of you have to leave on the dot, actually, so I do apologise. Delighted to see you again, Habib, here, and we've seen each other a number of times in various other areas. So Dr. Habib Naqvi, and also Bola, as always, good to see you on this topic. But Chris, do you want to open that topic?
Hello, my name is Chris Hobson. I'm the Chief Strategy Officer. And Richard, as you know, this is our regular opportunity to discuss our work on reducing healthcare inequalities, including the work of the Race and Health Observatory. I think it's important to note, Richard, that this is a priority for the new government, and that's come across clearly in a number of the ministerial meetings that we've had so far. Worth saying, I think, that the manifesto on which this government was elected stated the UK has stark health inequalities. It cannot be right that life expectancy varies so widely across and within communities. As part of our health mission, we will tackle the social determinants of health, halving the gap in healthy life expectancy between the richest and poorest regions in England. The paper that we've circulated sets out the approach and the infrastructure we've developed to reduce inequality in the area where we in the NHS have direct control, and that's the actual delivery of healthcare services. But obviously we need to recognise that we'll want to join with government, other public services, our voluntary and community sector partners and the nation as a whole in tackling those wider determinants of health to deliver the government's wider health mission. The paper just sets out, I think, really clearly how we've created the Core 20+5 framework, which sets out really clearly, I think, for frontline healthcare delivery organisations, gives them the means of understanding what action should be being taken and why it's important. It sets out how we've built a consistent delivery network across the NHS to ensure that local NHS organisations have got the capacity and capability to do what's needed. It sets out how we've created strategic partnerships, of which our partnership with the Race and Health Observatory to tackle race and health inequality is key. It also sets out how we've provided guidance to support frontline NHS organisations to take action in the required areas of intervention. But the next bit that we now need to do, having set up that infrastructure, and you might argue is the key challenge, it's to ensure that we do measurably reduce healthcare inequalities and that we have the right means to measure that. And again, we've set out in the paper about how we are doing that. But look, Richard, what we thought we would do is really bring this to life by asking Habib and then Bola to just basically set out some concrete examples of how the work that's been done over the last year has really made an impact on the ground. So Habib, why don't I pass over to you?
Great, thank you, Chris. Habib Naqvi, Chief Executive of the NHS Race and Health Observatory. Over the last year, the Observatory's work can be grouped into three areas, looking at bringing together the evidence base where it exists or establishing it where it doesn't exist. Secondly, turning that evidence into policy recommendations for change. And thirdly, supporting the system with regards to improvement and change. So I'm just going to give a very quick couple of examples on those three areas. Firstly, last year we published the We Deserve Better report looking at access to healthcare for people with learning disabilities. You may remember the stark statistic around life expectancy. If you're a white person with learning disability, your life expectancy, your average life expectancy is 62 years. If you're from a black or Asian background, it's only 34 years. On the back of that report, and since publishing that report last year, we've seen recording of ethnicity introduced into GP learning disability registers as part of the quality outcomes framework for health checks. We've seen awareness raising within communities around annual health checks. On Tuesday this week, I was with the Race Equality Foundation and Learning Disability England, where they've produced community videos that will be distributed out. And thirdly, we're looking at the nursing workforce as well, increasing representation within the nursing workforce, and particularly the learning disability nursing workforce, from people from an ethnic minority background. Also last year, we published the Racial Inequalities in Neonatal Testing report, looking at the racial bias that exists in some clinical tests, such as the APGAR score, and in testing for jaundice, for example. We're taking that forward, some work that we've just commissioned Manchester University NHS Foundation Trust to look at jaundice testing and in particular looking at transcutaneous bilirubin monitoring devices which test and follow the process through in terms of diagnosis of jaundice. And also, earlier this year, the Chief Midwifery Officer wrote a letter to all hospital trusts offering mannequins and birthing simulators in different skin tones on the back of our report. And within 24 hours of sending that letter out, 100 maternity services actually responded positively to that offer. And now we have nearly every single maternity service across the country that has simulators and mannequins in different skin tone and different skin colours. With regards to policy change, our very first piece of work looked at racial bias in pulse oximetry. This was at the peak of the pandemic. On the back of that report, there were changes made to the NHS Choices website with regards to guidance on home pulse oximeters. NIHR put out a very substantial call for further evidence, particularly from the UK, on that area. And the Secretary of State for Health and Social Care at the time announced a government-commissioned independent review looking at equity in medical devices, which we were grateful to see published earlier this year, led by Dame Margaret Whitehead, which emphasised the recommendations that we put in our report as well. And then implementation, which is the third area. Earlier this year, we launched the Learning and Action Network, looking at the stark inequalities that we see in maternal and neonatal outcomes, working with other organisations such as the Health Foundation and the Institute for Healthcare Improvement. We've introduced an anti-racism approach to quality improvement, which we're modelling with regards to maternal and neonatal outcomes, using that as a kind of test model or proxy to look at other conditions in due course. So we will be evaluating and hopefully scaling and spreading the good practice that we get from the 8 ICS pilot sites that are undertaking this programme across the country. And we were grateful for the support of the CNO and the Chief Midwifery Officer at the launch event in January. Looking ahead, we'll be launching our strategy with a new contract and a new work programme for the observatory in the autumn, not just highlighting, as Amanda says, the scale of the challenge, but coming up with some very practical solutions to those challenges.
Thank you.
Thank you, Chris.
And Bola?
Thank you, Chair, and thank you again for the opportunity to update the board in terms of the programme of work we've been driving forward over the last year. I'm just going to talk through how we've arranged our work and some specific examples of what's been going on. So firstly, we've worked to focus system, effort and investment on our most disadvantaged people and communities around 3 things. 1, the 5 strategic priorities that we've set out, the 3 recovery plans from NHS England, and the core 20+5 approach as has been described. And the examples I'm going to talk through then talk about those 3 themes, if you like. Peter and David earlier on alluded to the targeted lung cancer check program, which I will hold up as a great example within the core 20+5 framework, that when we focus investment and energy in a particular part of the population, we can demonstrate impact. So the increase to 76% of early stage cancer diagnosis has actually been largely due to the bottom 10% of the population, which again is just a great example of the targeted investment and effort. In relation to sickle cell disorder, which affects predominantly people of Black African population groups, we've had Amanda's mandate and executive sponsorship to drive forward a program of quality improvement in that regard. And I just want to call out a particular example of the voxelotor drug, which is now available to people living with sickle cell disorder. And when you consider the inequalities in the product pipeline, it's a really important advancement that people with sickle cell now have access to this medication that reduces their need for blood transfusion, and therefore it's good for the patients, it's good for the NHS, it reduces the frequency of crisis, and so from a patient experience point of view, it's a very significant step forward. Also, in relation to the Urgent and Emergency Care Recovery Plan, we've been working with the UEC team on the high intensity use service. And a great example is at New Cross Hospital in Wolverhampton that I've seen a 58% reduction in people using accident and emergency, especially amongst the highest users of A&E. They've looked at their data, and 60% of the people who were using A&E disproportionately were from the most deprived communities. And so a 58% reduction in that utilization is a great example again of how actually action to tackle health inequalities can make a material contribution to reduction in service pressures for the NHS and boost our productivity as well. Amanda referenced innovation in your opening remarks, and I just wanted to describe the Innovation for Health Inequalities program, which is a significant investment that was made last year in collaboration with the Accelerated Access Collaborative. And an example of where that has worked is with health innovation in North East and North Cumbria, where they focused on their South Asian, Black African, and the most socioeconomically deprived white population group to increase the diagnosis of high cholesterol in these groups. The board may be aware that raised cholesterol is associated with heart attacks and strokes, and they were able to demonstrate an increase in the diagnosis of high cholesterol in the populations that will otherwise not have come forward if not for the Innovation for Health Inequalities program. I also then want to finally talk about dental. So NHS Suffolk and North East Essex ICB under the leadership of Ed Garrett, and I commend his blog that came out yesterday to the board. They have entered into a creative partnership with Suffolk University to deliver an NHS-only dental service, focusing on homeless people, carers, and also care leavers, really to focus the investment on the most vulnerable people in that ICB. And it's achieving two things. One, access to dentistry for the most vulnerable population groups, but more importantly, the training of the dental workforce is the thing that is particularly striking about this model. And to reflect on why some of these initiatives are gaining traction and making a significant difference, I just want to talk about the core themes. One is the tight definition of the population of focus, tightly defined interventions, targeting of the funding, strong leadership that actually drives action and protects the resources for these activities, and having a very clear mechanism for monitoring progress. And it leads me to Chris's point earlier on that as we go forward, we really want to pivot from input measures into impact measures. And therefore, we present appendices 1 to 3, setting out the metrics and the indicators that we believe are really crucial for NHS England and the NHS more broadly to be able to demonstrate measurable progress in reducing health inequalities over time. Thank you.
Thank you very much. So I'm going to give just the floor for a moment. We'll quickly go. I can see Mark's hand, Amanda. So Mark, do you want to go? Duncan, Mark, Duncan, Amanda, and then I'll probably...
So I just want to really congratulate both of you. I think it's spectacularly good work, and it's very nice. I thought the diagnosis was very nicely laid out in the paper and the impacts in your presentation. And I think my question is, have you been put in touch with Lord Darcy for his review? Because it seems to me that given the importance of this as one of the government missions, it's really important that he has the chance to take evidence from you.
Thank you. And if not, that is that will. Well, we're saying that can happen or will happen. Duncan, you were going to.
Yeah. Well, it was really just to say that, you know, I think the NHS is here for everyone, but this is a really, you know, the work that you are doing just clearly demonstrates actually we need to do things differently for some people to make sure that we are here for everybody. And I would just say, I think this is also a really good example of making things really simple and practical. You know, if you look at Core 20+5, people talk about it in the system. You know, the work that's been done on neonatal, I go out to neonatal units, they are talking about it. So I think that we need to continue to do the work, which is actually making this really practical. And just the last point really around the anti-racism approach, I think, you know, I think we need to really, when that reports, really understand what we therefore need to do across the board to make sure that we really live that.
Helen, you wanted to make... so we're doing this batching up, so it's that same thing of can you react at the end of the batch, as it were. Helen and then Amanda.
Mine will be super quick. I just want to say, again, huge thanks to both of you, all of you, Chris as well. You know I'm a huge fan of this work and have been from the outset. You had a specific question to the board, and that was about comments on these indicators, these updated indicators. I think they're fantastic, and I think they're a natural evolution. So from my point of view, we haven't discussed this, but yes, absolutely, make it so. I don't know what others think, but thank you so much for your ongoing work here.
Thank you. So, look, once again, it's a real pleasure, in fact, a privilege to have this conversation with both of you. I'm really demanding in this area. I always want three things. I always want, which by the way you're giving me, so I just cue you into that, the evidence that we can make impact at scale, which is this inclusive recovery. How do we get ourselves to a situation where we can't claim success unless it's inclusive success? Secondly, I obviously want to see us driving again at scale improvement in the areas that are specifically the priorities for Core 20+5. But thirdly, I also want us to be able to do the thing that Habib, you do brilliantly, and Bola, which is really zone in on those areas where we've got problems, be great at shining a light on them, have the practical action that says, okay, we're going to do something about it, and then our ability to hold ourselves honest to the follow through. So the thing that I just want to suggest, I've just checked with Richard that he's happy for me to do this, and he is I worry that once a year isn't enough for us to be having this conversation at board level, because this requires a really different way of working for not just NHS England, although it is NHS England, but actually across the organisation as well. So I just wonder if what you might allow us to do with you, and Richard's happy with this, is to think about linking you more formally into one of our subcommittees, potentially quality. I'm looking at Robert, just so that we make sure that we're really wrapping around this agenda in a more regular way, as well as, so it's not instead of, but as well as the thing that you do both within our executive forum and within the board more generally. And so my question to you is, would that be helpful? And while you have the floor, is there anything else, I guess, you'd like to be demanding of us, given that I feel like we're pretty demanding of you?
So why don't you answer, to the extent you want to answer those two questions now, particularly the second one, but actually, and then just react, and then I'll bring the meeting to a close. But it's a very good conversation. So, Ola, Habib.
Yeah, thank you so much, for the level of engagement with the conversation. And I just want to say thank you so much, Chris, because we've had some very focused conversations that have been driving our increasing focus in this area. So I just wanted to acknowledge Chris's incredible support. Amanda, thank you. I think in terms of your specific question about how can we be even more demanding of the organisation, I think it's Helen's point about the metrics and the indicators, and it's how they are now built into our pipeline of data reporting, whether that is within the executive packs, the regional quality assurance processes, and indeed through the board committees, and as you described, the quality committee specifically. I think that would be incredibly powerful, because it means that we can have a focused data-driven conversation to guide our progress. So yes, please, that would be a very specific ask. And yes, in relation to the Quality Committee, we have an affiliation there, but something more formal, in addition to our annual reporting to this board, would be hugely welcome. I just wanted to respond to those two things specifically. But I'm sure Habib would want to come back on some of the other points.
I'll be very quick, and I'll respond to both Duncan and Amanda's points together. I think one of the reasons for the initial impact of the observatory has been how we've been engaging with policy leads, particularly from NHS England, right across the directorates. And therefore, Duncan, your point around looking at the anti-racism approach, the evaluation scale and spread of that will benefit from those connections that we make, particularly within NHS England, as well as other ALBs. And therefore, the Quality Committee question, I think, is an important one if we can embed ourselves, just as we have, just as the Observatory has with innovation and the accelerators, I think will be a good move forward.
Thank you. Chris, do you want to...
Just one observation, really. Well, two observations. First of all, just thank you again to both Bola and Habib and their teams. They do a fantastic job. Just in terms of one extra thing that all of us, I think, need to do is, as we've said before, what gets measured gets done. And we've got very, very busy programmes in terms of cancer, urgent and emergency care, elective. It's actually ensuring that all of us as executive colleagues effectively embed the importance of the measurements that we are now seeking to do in this space and have that as a key part of how we report performance, recognising that there are a number of other areas clearly where those programmes will need to be focusing. So that's, I think, our collective task as the executives, to actually really embed that and focus on it in an appropriate way.
Yes, thank you. So, Habib Bola, thank you very much. Very good conversation. So there are 3 items starred for information only. If there are any key questions, do you want to pick them up with me outside the board? But they're relatively straightforward, noting of directions we received, 2 from the Secretary of State and 1 from Digital Healthcare Wales, which we've adopted. Thank you very much. I'm going to quickly pause and see, has anybody, because the board has been going since 9 o'clock this morning, and we've had 15 minutes break. And so otherwise, I commend the energy and application and commitment and enthusiasm of the board, and I apologise for not allowing for actually losing the agenda so the breaks got crushed. But with that as an introduction to, has anyone got any other business? So, yeah, and if you have, anyway, and thank you very much. I call the meeting to a close. Thank you.